Hello. So remember, said ki if there is a workup breathing, mild workup breathing, I would not start oxygen. But the simultaneously, if it is the same child coming in the worsening phase of the disease in your emergency, or you're in the OPD or in the hospital, it's okay to start oxygen. Don't feel bad about it. Remember, in emergency, since last 15 years, all of us were over treating in the emergency. Why we treat over? Because we get a sense, we get some time, 30 minutes, 40 minutes to get a sense what these kids are having. They're deteriorating, they're improving. So it's okay to over treat them. So it's really important when we are talking about workup breathing. So we have an ABCD approach, which everybody know: airway, breathing, circulation. So in an airway, in a workup breathing, what we see, the first thing is we see is, are they able to maintain the airway or not? They're able to maintain the airway or not, or this child requires some suctioning or some maneuver so that the airway is open. Breathing, how they are breathing. Is there any increased work of breathing? What are the crepitations? What is the saturation? Okay. And then subsequently, there are few other things we see when we attach to the monitor, a saturation. So these are the few things we require. Even if the saturation is not there, there are a lot of things you can identify. If you see any of the severity classification of workup breathing, it doesn't take saturation into account in most of them. You can identify or define workup breathing, mild, moderate, severe, just based upon the clinical examination. Why saturation? Because just you will see a child who is having severe workup breathing, asthma, but they are maintaining saturation. So saturation can be a plus minus, and saturation is something which decreases when you kind of, what is a minute ventilation? So how much of a breathing in a kind of, how much of a volume going in and out of the lung in a one breath into your respiratory rate. So in that situation, what happens? The first thing is, if you're not able to maintain saturation, you start breathing faster. But you'll maintain the saturations. But after some time, if you're not able to do that, then your saturation start going down. So airway, breathing, circulation is important. Identifying airway not maintained, maintained with support, or maintainable in the sense, do you need to put an endotracheal tube, or you just have to put an oral tube? Do a simple section. It's really important. Classify respiratory distress. So we are going to see how to classify this respiratory distress. What is a definition most of the time we use, and what is actually epidemiological definition? We have to see how we can stabilize them with the simple interventions. It could be nebulization, it could be an NRM, it could be just position, it could be a simple suction. There are a lot of patients, bronchiolitis, we come, what we do is we start oxygen, then we realize there is a nose block. We do a suction and they're absolutely happy. So it doesn't mean that you have to do a very high intervention. And once you are fine with the primary assessment that your airway is stable, breathing is fine, then you go to the secondary assessment. You are not supposed to go to the secondary assessment unless and otherwise there is a primary assessment tools are completely confirmed and they're fine. So the story is, whenever child is coming into emergency or in your OPD and in your hospital, assess them for breathing difficulty. If there is a breathing difficulty, do intervention. It could be just oxygen, nebulization, suction. Sometimes it could be intubation. Sometimes it could be an oral airway. And we'll talk about the workup breathing. Why it is not changing? Click on that. Okay. So what about respiratory distress and failure? When we talk about respiratory distress and failure, there is a one term always we use, impending respiratory failure. Is it something which anybody can define what is impending respiratory failure? Anybody can say what is impending respiratory failure or define impending respiratory failure? There is nothing like that. Either there is a respiratory distress or respiratory failure. But the most question, the common question comes in our mind is respiratory failure means the child needs intubation. Is nothing like that. Okay, respiratory failure doesn't mean intubation. So respiratory distress, these are the few things, soft pointers. Okay, so in a respiratory distress, you have a tachypnea, mild to moderate respiratory distraction or retractions. The child will be a little bit irritable because they are hypoxic. Saturation maintained in a room air or require a mild kind of a things. I would say low flow oxygen, and they can able to maintain this airway. This is a soft pointers toward the respiratory distress. We can share presentation in a PDF format, so don't worry. Just concentrate on all those things. Okay. Respiratory failure. So respiratory failure is, again, this is a very sketchy definition. Severe tachypnea and retractions. You have exhausted bradypneic child, severely irritable, drowsy, low saturation in spite of high oxygen like NRM, and interventions to maintain the airway. Intervention in the sense, you might require the nasopharyngeal airway. You might require the endotracheal tube. These all qualify for respiratory failure. But a child who can have mild to moderate chest retractions can have a saturations of 60 also. So it's a very sketchy definition. But in the emergency, you always I said over. So if the child is respiratory distress, consider it's a respiratory failure. That's fine. Nothing is going to happen. Okay. Always try to kind of over treat this patient in the emergency, because the changing in the physiology very rapidly. Now, what is respiratory failure? So respiratory failure is very strict. Respiratory distress definitions are different. According to the PALS, respiratory failure is simple. If you are not able to maintain the saturation more than 92 and requiring more than 50% of FiO2, this is respiratory failure. It could be in hypoxic respiratory failure. Then PF ratio. We have been seeing the evolution of this PF ratio since long time for ARDS. So PF ratio, which is less than 200, qualifies for, again, respiratory failure. PaCO2 more than 65 or more than 20 from the baseline. That means you are having the hypercarbic respiratory failure. Okay. And third thing is, any child who is crashing into your emergency and requiring non-elective mechanical support. It could be bag and mask for few breaths. It could be intubation. It could be an oral airway. These are all qualify for respiratory failure. This is a definition of respiratory failure. There is no change. So any child coming into your emergency, saturations of 90, 85, you started oxygen, low flow oxygen, which is 40%. The saturation is 90. Then you change it to NRM. The saturation is 100. It's a respiratory failure. Respiratory failure doesn't mean you have to intubate. Okay. Now, these are the different types: hypoxic, hypercarbic, neurogenic, and the common word we use, impending respiratory failure. There is nothing like impending respiratory failure. By using impending respiratory failure, what we do, we try to convince ourselves this child is not in respiratory failure. This child doesn't require intubation. So when you are trying to convince yourself that this child doesn't need intubation, that means the child has already qualified for intubation. Okay. Always remember, when you're convincing yourself, no, I'm not going to intubate this child, that means this child needs intubation. Now, these are a different breathing pattern. Most of this we have learned when we are kind of in MBBS and all. So you have a normal breathing pattern, tachypnea. So what is happening in a tachypnea? I would go into the physiology. Same thing. You're trying to maintain the minute ventilation. How much is a minute ventilation for a grown-up adults? It's 4 liters per meter square body surface area. For females, what they say, 3 to 3.5. So any child, you can calculate that. Go back.
Significant.
I'm able to do tachypnea. So you are able to maintain. Why you are doing is you are increasing the respirator to maintain the minute ventilation. So in bradypnea, what is happening in the bradypnea? It could be a normal bradypnea that you are able to maintain your minute ventilation by low breathing. But most of the time, this is the terminal kind of a breathing when you're breathing very less, or you have some systems or problems into your brain. Then you have apnea. You are not breathing. Everybody's hyperapnea. Usually what we see in hyperapnea, rate and depth is increased in acidotic breathing. You can talk about Cheyne-Stokes breathing, again CNS kind of thing, Bittot's, Kusumals, apnea, all those things we usually don't see, and we kind of see in most of the patients with CNS diseases. Now, different kind of sounds what we say. Again, I'm not going into the detail of that, but just to differentiate between the two, if you see, upper airway, we are very clear. You will have a stridor, you have a gurgle, you have a retractions, and then depending upon what physiology you're talking about, report signs and all those things, all common things will be there when we are talking about upper respiratory. Lower respiratory area, you have airway and parenchymal things. So remember, most common thing we see in our OPD is bronchiolitis. So what is bronchiolitis? Is it a disease of a smaller airway or a little bit of a larger airway? Okay, so bronchiolitis is more than the respiratory bronchioles. Below the respiratory bronchiole, if it is coming, then probably you might see a little bit of prominence. So most of the bronchiolitis, you qualify it. Actually, when you auscultate, it's a wheeze. Actually, it's not wheeze, it's a bronchi. It's coming above respiratory bronchioles. Why it is coming? The physiology in bronchiolitis is, so this is an airway. The airway is not getting narrowed in bronchiolitis. Why? because you don't have a beta 2 receptors till 6 months to 1 year of age. So you cannot constrict your bronchus or bronchioles. What is happening is there is a swelling and there is a secretion inside. That's why the actual size of the airway is lowering down. So that's why they said in a bronchiolitis, you should not give levoline, you should adrenaline and normoxylane and all those kind of things. So there is a difference between when we talk about rhonchi and wheezing. Rhonchi are little bit of a low pitch sounds. They are not staying there for longer time, but wheezing, they are high pitch and they stay there for longer time, specifically in the expiratory phase. Then you have coarse crackle, fine crackles. When you're talking about parenchymal, coarse crackles mainly suggest some kind of a secretion inside the airway. Then there are intercostal, subcostal retraction, but this is very sketchy. It's not like that. Even parenchymal, you can have intercostal and substernal retractions and other clinical symptom associated with diseases. So when we are talking, again, this is a pulse, mild, moderate, and severe. When you have a nasal flaring and subcostal retractions, it qualifies for mild workup breathing. When you have an intercostal retractions, whatever your rate, saturation doesn't matter here, irrespective of that. If you are having moderate workup, you'll have intercostal retractions. And we are talking about severe, suprasternal, then you have supraclavicular retraction and sternal retractions in the infantile age group is qualifies for severe workup breathing. So this is very clear when we are talking about that. And we are going to see a lot of videos where you are going to tell me which kind of a workup breathing we're talking about. There are different diseases, etiological classification. Excuse me. Can we get this out? Yeah. The ऊपर वाला जो है. हाँ. नहीं. You get the arrow down, it will automatically go. Arrow नीचे करो. हाँ. ठीक है. So this is different etiological classification, but commonly I would say upper airway we see croup, lower airway we see bronchiolitis and asthma and pneumonias, or what we call as a wheeze associated lower respiratory tract infections. So this is the etiological classification. You have to click on this. Click karo ek bar. That's it. So no respiratory causes of workup breathing. We know there are a lot. You have certain times the patients are sent to us as an asthma, but found out to be diabetic ketoacidosis. You have LGBS, early LGBS with the diaphragmatic illnesses. Then you have something in space occupying lesions. You have raised ICP. You have traumas, which actually qualifies for some workup breathing, but there is no problem into the brain. So these are all the other things which is considering. You have a paradoxical breathing, cardiogenic pulmonary edema. So there is a respiratory cardiac issues, which is causing increased pressure into the lungs and the blood vessels, and lungs are flooded with water, and you have workup breathing, metabolic acidosis, septic shock. In a septic shock, what happens is if you see a lot of these patients are tachypneic. The reason is not they're having a workup breathing or pneumonia. The reason is they're increasing their delivery oxygen, or there is a good amount of oxygen requirement in the body. That's why they are tachypneic. So if you see this patient, once they improve, the tachypnea goes down. Now we are going to see the videos to see what kind of a sound. So this is a child. So what kind of a workup breathing is this? Which workup? It's a mild, moderate, or severe? Anyway, severe. Why it is severe workup breathing? First, so this child is listless, apathetic. Even if he is not having any upper respiratory tract obstruction signs like suprasternal retraction, still it is a severe workup breathing because he started being encephalopathic. There might be an hypoxia. And another, so you can see out here, you have what you call so it's a severe workup breathing. बंद कर उसके ऊपर क्लिक करिए स्क्रीन के ऊपर नहीं ठीक है this is another child. Again you see what's this mild, moderate, or severe workup breathing. So respiratory rate, if you calculate, it comes normal, but look at the child. So there is some intercostal retractions, subcostal retractions, and child is listless. So if you put all the definition, you might say this is a moderate work of breathing. He's not breathing faster. But here we know that the child is very listless, not moving and all. So you should not be dogmatic about your diagnosis. It would be moderate to severe work of breathing. Having said that, probably we all of us will treat him like a severe work of breathing. We'll see whether the airway is maintained or not, give a position properly, give nebulizations and all those things. You click and just leave it, okay? Next slide. Same slide you're saying. That's. So now this is what is happening here. So this is a mild, moderate, severe work of breathing. So if you calculate the respiratory rate, it looks fine. But if you look at the child, what is happening? What kind of a breathing he's having? So this is a guy who will actually qualify for, when we said non-elective mechanical support, ventilatory support. So this is a child. He's having a jerky breathing. He's not able to lift his chest also. So this is a lot of impending respiratory. It's not impending respiratory. It's a respiratory failure. This child requires intubation. So this is a respiratory failure, which requires now you see this. एक मिनट, आप कुछ नहीं करें. The respiratory rate is normal, probably not requiring much of an oxygen also, but what is the commonest diagnosis here? All of us we see. It's a croup. So basically, this is again severe work of breathing because we don't know what exactly going to happen. This child requires severe. So respiratory failure or severe work of breathing. Can you play that? So this is classical. This is grunting or moaning. This is grunting or moaning. It's both. Okay, almost. So what is grunting? What is grunt? So when you are actually trying to kind of breathe out when the glottis is closed. So you are kind of a more tachypneic. You are not able to hold off your functional residual capacity. You are not able to keep the lung inflated even in the expiration because the glottis closes and there will be something stays in. And this is kind of a grunt. And moaning is basically when there is an excessive parenchymal involvement. So both the things are there, and this is qualifies for the severe work of breathing. So now this child is crying, looks quite alert, but he's breathing faster. What do you feel? What could be the work of breathing here? What would we do this child when it comes? So you can say it's probably so you have subcostal and some intercostal retractions. The child is crying. Why crying is important, you tell me, in a respiratory things? Whenever a child with the respiratory distress comes and child is crying, vigorously crying, what it tells? So crying is a very good. So when we cry, we exhale. Okay. When we cry, we exhale. And if you are able to cry it for longer time, that means these are the kids who are having a good functional residual capacity. They have a very good respiratory reserve. If you see most of the child who is having work of breathing, they will be a little bit cry for a second and they will stop. That they wanted to breathe in and then they will cry. But this is a child persistently crying. So probably you can reasonably say this is a respiratory distress. Probably this child will not go into the respiratory failure. This is a soft pointers that you are able to maintain the functional residual capacity, might not go into the respiratory failure. Now this child is on NRM. You can see there are, it's not there. So you have some kind of a subcostal, intercostal retractions, some suprasternal retractions. Look, this age group child, I would expect more fighting. So this is, in spite of NRM, this child is kind of having a work of breathing. So this qualifies for respiratory failure and severe respiratory distress. Respiratory failure requiring more than, this is 100% FiO2, and you have saturations, is tachypnea is still there on 100% FiO2 qualifies for severe work of breathing and respiratory failure. So when we talk about it, as I discussed so many videos, what we'll do, these are the few interventions we do. What we do, we might give nebulizations. Our first thing is position, suctioning, doing it fine. So few patients will require nebulizations. If the things are not looking fine, we might go to the low flow oxygen, or both the things might be there together. Then there are patients where we are not able to understand what kind of a work of breathing, but it's absolutely okay to start NRM in the emergency setting. If we are reached to that extent that on NRM also. So remember, I started NRM and saturation is 100. The previous child, saturation was 100. Respiratory rate was 47. So does it mean we are happy? We are not happy. The reason is we are giving 100% oxygen and we are seeing fallaciously high saturations because we are giving 100% oxygen. So these are the kids, if you don't start any pressure in the form of high flow oxygen or CPAP or all those things, these patients might get deteriorated over the time. And we call it the denitrogenation atelectasis. More oxygen you will give in alveoli, it will be only oxygen. So they will start collapsing or they will have a biotrauma. So this is not the things that we are going to give NRM for longer time. So these are the kids might require high flow oxygen, then depending NIV, BiPAP, bag and mask ventilation, and virtually intubation. So this will be in most of the time escalation ladder. And we have a presentation where we'll talk about it, how we do it, how we take it. Thank you very much. Any question related to that briefly? So simple, any child coming, you either qualify into the respiratory distress or respiratory failure. While saying that respiratory distress and respiratory failures are different entity, the mode of treatment route remains the same unless and otherwise the child comes and requiring non-elective mechanical support. It is absolutely okay to over-ventilate or overdo the things. There is a good terminology we call, there is a lot of papers we see Friday night ventilation. That means Friday evening some patient came and looking severe work of breathing, is absolutely okay to intubate them for 2 days and extubate on Monday. This is a world known things, Friday night ventilation. We don't want them to get compromised and die over the weekend. So intubate them, keep them comfortable and extubate them on Monday. That's absolutely fine. There are a lot of units in India also. Sepsis, septic shock patient comes, you give a lot of fluids, they start breathing, they give a CPAP for a few hours, things are fine, they remove the CPAP and shift them to the room. So it's absolutely okay to overdo the things. But the most important thing is the first, you identify, evaluate, intervene, and again keep on doing the same thing. Otherwise, you start CPAP and you give NRM and you went and you kept on watching the monitor, saturation is 100, but you don't know the respiratory rate before starting NRM was 50. Now it is 60. But saturations are fine. Why? Because you are giving 100%. You are not giving pressure. NRM doesn't give any pressure. Low flow oxygen, high flow oxygen, heated high flow give it, but eventually face mask oxygen, nasal prong oxygen will never give any pressure. So it's only oxygen delivery.
So now we will be moving to second talk of the day. I'll invite Dr. Chetan to proceed. Sir.
Good morning, all. First of all, I thank very much Dr. Nitin, Dr. Suman, the whole team of CUDDLE Gachibowli for making me a part of this. And it's always good to have a talk after somebody like Parag who keeps you in rapt attention. So it makes my job easy. Before we proceed, I just want you to have full attention and I want you guys to interact also. So we'll start with a simple exercise. You just have to follow me what I'm doing, you have to do, okay? So you all raise your right hand. All right. Raise your left hand. All right. Raise your right hand again. All right. Then after raising your right hand, just close your face and put it to your chin. Only very couple of people only have put it on chin. Everybody put it on the cheek. So that's what our attention is, okay? So we have to focus on it. And I think I'll ask our organizing people to have tea ready so that, you know, you can have undivided attention and focus. All right. So as Parag described, like you identify a child with respiratory distress, and then you go for escalation. Okay. So go for intervention, whatever you want. So before, are we ready with the presentation? Yeah. So this whole workshop, I'll just give you a background, was conceptualized by all of the team, Cuddles, Parag, Nitin, and many people have put up their work. So my presentation is largely the framework has been done by Dr. Avinash. I've just borrowed the slides and I'm here with in front of you. So once we see a child with respiratory distress, and as Parag mentioned that, and Parag mentioned that you see a problem in your initial assessment and you address it, and then you move forward the next step of your stabilization of your sick child. So we'll go with a simple case scenario, and we'll see. Yeah. So we'll describe a case, and we'll, with the help of the case, we'll just decide how we decide about, moving on with our therapy. It's not coming. Slide changes. There are no videos. Yeah. So this is a 5-year-old boy who has presented with complaints of fever for 5 days, cough and cold for a week, and hurried breathing. And when he presented to ER, there was a breathing difficulty for last 12 hours, the parents noticed. And it's again going back. Yeah. So as you can see, is 20 kilos, is patent and maintainable airway with respiratory distress, and he's saturating around 91% on room air with low flow nasal prong oxygen is 96%. There's a distress, there's bilateral crepitations, and he's fairly okay hemodynamically, and with little tachycardia with a temperature of 1 or 2.6. There is no rash. The sugar levels are okay, and child is dull, is interacting with mother, but it is little dull. So that's all we have with this. So next, please. So we started with oxygen in the ER. And so how do you deliver oxygen? You deliver oxygen either, as Parag just mentioned, low flow delivery and high flow delivery. And in low flow delivery system, you just provide a little bit of reservoir of oxygen for the patient to breathe. Those who are little stable patients, but little support, you use this, and you most commonly use nasal cannula and also face mask. Whether it is Venturi or normal face mask, it is still a low flow device. High flow systems, they deliver constant FiO2 by delivering a high flow with your set FiO2. And usually it exceeds the patient's, it has to exceed the patient's peak inspiratory flow rate by 2-3 times. And non-rebreathing mask, the high flow nasal cannula, these are the example of doing it non-invasively. No, it is not moving here. All right. Okay. Yeah. So child got shifted to PSU after 2 hours of initial counseling and all the formalities and stabilization. So he's again tachycardic on NRM. He's 92% saturating. His blood gas is showing a little metabolic acidosis with maintained lactate, and his counts are 18,000. His X-ray is showing a right homogeneous opacity, which is likely lobar pneumonia. So he was started on heated, humidified, high flow nasal oxygen, and the flow was 25 liters per minute. His FiO2 was kept at 50%. and the RR was around 40 per minute. So we started with that, and whenever we are coming across any child who is sick, who needs immediate attention, we have to spend a little more time with parental counseling. That is the single most important thing, which makes our job easier for the next few days with the patient care. Because nowadays, more and more patients, they have this suspicious mindset. And it is important also from a parental point of view to let them know what exactly is child having and how are you going to deal with it. What are the future probable potential complications which may arise, and how are you going to address those, and how are you going to escalate? So whenever you are doing some intervention, you have to first make the family understand why we are doing it, what we are going to achieve of it, how we are going to monitor for that, and how, if this is not working, how are you going to proceed further. So when you keep them informed, when they also feel little empowered and they start understanding it. Initially, it may not be that much evident in, because the parental mindset is like, initially they will be sort of in denial mode of having a child who has got severe problem. He was fine 2 days back and now you're saying all this. So we have to be patient. We have to keep telling them the same thing repeatedly if they don't understand. But spending that 10-15 minutes of time initially and the very outset of the interaction of the healthcare team as well as the parents, it makes our job a lot easier afterwards. So how does this high heated humidified high flow cannula work? So last almost 7 to 10 years now, it is in vogue. It is very commonly used because of the ease of use, the patient comfort, and fairly good efficacy in milder cases. It has become a mainstay. I mean, everywhere now people are using it, even in smaller towns and districts also, people have started using it. So it's a very well tolerated mode of support. And basically what we do is we give a fixed FiO2 with higher flow, 3 to 4 times of the minute ventilation of the child. We give that, and it is heated and humidified. So how does it help? How does the heated humidification and the high flow delivery helps? So first and foremost is the nasopharyngeal space, which is a fairly big dead space, especially in small children. So it washes it out and it fills with the heated, humidified, and the particular FiO2 oxygen. It fills it up with that. So it improves the oxygen concentration of the inhaled air, and it also reduces the inspiratory work, the inspiratory resistance, by providing a flow which is more than adequate. So if you have a higher flow, the child doesn't have to work that much to inspire. So you reduce the work of breathing. You also, a little bit of continuous descending pressure is achieved by this. So there are various studies. When I remember when I 17 years back, when I was in Australia, they were doing this. It was not in vogue, and they used to have the impedance manometry, and we were seeing that high flow, adequately delivered high flow will give you around 4 to 5 centimeter of positive and respiratory pressure. So all it does is it provides you a continuous descending pressure, and it improves the atelectasis. It improves the oxygenation. The heated humidification of gases, it first prevents any drying of the respiratory mucosa, and it also gives you little mucus clearance. So it also improves the mucus clearance by liquefying this sputum and making it easier for the child to get rid of the mucus. So all these combined together, they lead to improved clinical outcome. It is very much useful in smaller children with bronchiolitis, milder pneumonias, any child with mild respiratory distress, mild to moderate respiratory distress. Many a times if we give this and our other therapies start working and the child gets better, and we don't have to look beyond this. So once it has become more and more in use, the number of bronchiolitis kids who have got ventilated had drastically come down. So that is how useful the heated humidification of high flow nasal cannula is. So as I said, where do you use it? You use it in mild to moderate respiratory distress with bronchiolitis, asthma, and pneumonias. And many a times post extubation, where the child has been having either really bad lungs or has been prolonged ventilation, and you expect that some sort of support will be needed. The child won't be able to have proper respiratory, like the distress will be there. So supporting the child post extubation. And how do you set it? So it is very simple to use. So the nasal cannula size has to be somewhere around half the nostril diameter. And why is that? We are providing high flow, then why not give the cannula, the larger the diameter, the lesser the resistance, right? But here we have to understand we are giving a very high flow, which is heated to the room temperature. And that high flow, if we are putting very snugly fitting cannula, it can cause burns sometime. It can cause pressure change, necrosis as well. So it has to be half the nostril diameter so that there is some leak which can go out. The humidification is done at 34 to 37 degrees. And the FiO2 target is, you start at around 40-50%, but do not go beyond 60%, and achieve an FiO2 saturation of 95 around, so 92 to 97%. That is our target. And the flow rate, the first 10 kg, 2 liters per kilo. After that, 0.5 liter per kilo. After 20 kilos, 20 to 30 kilo, you can give 25-30 liters, and 30 kilo and above, you can give 40 liters. So that is the usual flow which we keep in kids. Then any intervention when we do, so the important thing is to monitor whether our intervention is having the desired effect or not. And if it is having desired effect, you carry on. If it is not having the desired effect or the child is still worsening, then you have to ensure that you are moving ahead and you are going ahead with the further escalation of your therapy. So how do you monitor? So the heart rate, the respiratory rate. So once you take care of the respiratory distress, you reduce the work of breathing by these methods, what will happen? The tachycardia will settle down. The respiratory rate will settle down. The distress, the work of breathing, the child has to work harder. So we're providing a support. If it is the child is responding, means the child will have decreased respiratory distress. And your requirement of oxygen, your child's overall well-being, the alertness, wakefulness, that will all improve. The blood pressure will also get better. So most important is when we are doing this, so all these devices and all is good, but it's also important to reduce work of breathing by all other means. So most of these kids, they will have fever. So hypothermia increases the energy expenditure quite a lot. So do not tolerate fever in these kids. So ensure that your team knows that if there is a fever, they have to take care, give antipyretics, do sponging, make sure the environment is appropriate. If your overhead warmer or something is there, ensure that normothermia is maintained so that we don't let the child lose that energy unnecessarily. So you then pacify the child. Whatever intervention we are doing in the initial stages, whatever interventions you are doing, do it in a manner which is non-threatening. Do it in a manner where child doesn't get more and more agitated. The more agitated the child is, the crying and all, that will increase the work of breathing further. So your child already has got respiratory distress, has got compromised respiratory system, and we should not be adding up on that. So ensure that whatever interventions you are planning, you plan it in a non-threatening manner. Use parents. So simple respiratory distress, let the child be in mother's lap and provide all your therapies, whether it is nebulization, oxygen, high flow. These things we can provide in mother's lap. But what that will do is that will have a soothing, calming effect on the child, that he or she is not in a foreign environment where there is nobody else, only some strange faces and strangers are there. So that will make the child more agitated. So we have to ensure that by doing all this, all we do is cut the expenditure. So when you don't have, say, if your income suddenly reduces, what you do first thing is you don't borrow. You first ensure that your expenditure is reduced. So here our suddenly the requirements have increased. So you cut the expenditure by all possible means so that your needs of escalation also reduces a lot. So once we see, okay, we have started, then we have to identify the non-responders, where things are not working, because we have to go up on the ladder now. If we don't act in time, as Parag mentioned, that once you have seen, okay, this child is not making any progress anymore, let me just go up, because if we let the child carry on, eventually the child is going to crash. Most of the pediatric patients who collapse or who have cardiorespiratory arrest, the 90% of the times it's the respiratory cause which causes this. So they start getting exhausted, and at one point of time, all the compensatory mechanisms, they break off and the child simply collapses. So to avoid that, we have to keep monitoring for all the parameters, and we have to identify the responders and non-responders early on. So as I said, whenever you have improvement in respiratory distress, improvement in tachycardia and respiratory rate, overall well-being of the child, and your FiO2 reduces. So what is the timeline for this? So once you start these interventions, like say high flow or even NIV, the 2 to 4 hours time is the time. Those who start responding, they show a little bit improvement in that particular time. Those who keep worsening, you have started with 50%, you are now on 70%, the child is still not maintaining saturation. Those are the ones where you have to escalate your therapy. So the non-responders, we have to quickly identify and we have to act accordingly. So after starting in this child, after starting 12 hours, initially the child was holding on okay, but then the there was increase of work of breathing, the FiO2 requirement went up, the child also there was a little CO2 rising, and he was still responding to oral commands, but he became more and more dull. So that is telling that now the child is getting exhausted, and our current therapy is actually not helping the child anymore. So we have to think about what next. So what are the next options you have? Sorry? So CPAP. So you want to first go for non-invasive ventilation, and another option is invasive ventilation. Okay. So it all depends on what the child is having. You by this time you will have a little more information with all your other investigations, and you will see other systems also. So yes, I mean, you can either have an IV here, or you can straight away go for invasive mechanical ventilation. But because the child is still having a fairly good sensorium, is hemodynamically stable, is having milder distress, we are hoping that our source control by starting antibiotics and all that will also start helping us. So you are justified in starting NIV in here. So whenever we are starting NIV, we have to, again, when you're using something, you have to understand when to use, when not to use, how to use, and what to look for wherever you are having your responses. So we have an algorithm called Iceman, where you identify the patient and type of respiratory failure where you are going to use this modality of NIV, where not to use it. That is very, very important. So any intervention you do, you have to first know when not to do that. Do no harm is our primary concept of medical care. What is the equipment you have, and is it suitable for the patient? So right from the ventilator or the machine of CPAP or BiPAP, which is going to deliver this NIV, and the interface, the patient interface. So all those things are there or not. What mode are you going to use? How are you going to analyze the child or to monitor the child? Whether the NIV is adequate, or should we be thinking about escalation, or should we be weaning? So these are the things we need to look at. So where do you use NIV? So almost similar to what we use in HFNC, but little more severity of disease also. NIV helps because there is a assured pressure delivery. In HFNC, we just assume, okay, we are giving this much, so this will be the translate up to 4 to 5. We cannot go beyond that even if we increase the flow. So any child with acute moderate respiratory failure with to facilitate early extubation, you can again any prolonged ventilation child who has still some other neuromuscular issues which are mild, which are not very severe, and or lung issues, and you want to extubate, you can use this. In a dynamic obstructive airway disease, NIV does help in asthma patients. Maybe tomorrow you will go for a look when you will get to hear about it. So those with neuromuscular disorder with intact reflexes. So reflexes has to be intact, but many patients will get benefited with this, something like DMDs or SMAs with intact reflexes. Cardiogenic pulmonary edema, again, somebody who has say PSGM and nephritis with acute hypertension. So this is something which is a transient kind of a problem. So where you expect, okay, once I start taking care of the blood pressure, the diuresis and everything will help. So we just have to tide over the crisis of this increased pulmonary edema leading to increased respiratory distress. You just give a little bit of NIV support for a few hours or maybe a couple of days. And once you take care of the etiology, the child is out. You don't need to go invasively here. So these are the patients. Basically, whenever you have a single lung organ dysfunction, moderate dysfunction, you can use this. Where not to use it? Anybody who is either in coma or in altered sensorium, or there is active bleeding from the upper GI, lower GI. So these are the, or they are having severe protracted vomitings. These are not the patients where you should be putting this. Any craniofacial trauma, again, because you need a very tight seal, so you cannot add burden to the injury. Multi-organ involvement or severe ARDS. So these are again patients where you can't really do that. Any recent gastric surgery, esophageal surgery, because NIVs invariably leads a lot of air goes in, a lot of flow of air is there with under pressure. So it leads to aerophagy, it leads to gastric distension, it leads to esophageal distension. So somebody who has underwent esophageal or gastric surgery, you can't really go for that. So why do we choose NIV? As you have also decided, the child had mild ARDS, had hemodynamically stable, was fairly alert, was looking around still, and responding to mother. So what kind of equipment? So you can have either NIV specific ventilators, or you can, most of the current day ventilator which we all use, they have some mode of other of non-invasive ventilation. So you can either deliver CPAP with pressure support, or you can even deliver BiPAP with the same ventilator, from which you can later, if needed, you can go with invasive ventilation. So, and they are the most common ones which we use in pediatrics at least. In adults, there are many patients who will, COPD patients who will already be on home ventilation at night for their obstructive apneas and all. So there, the use of standalone BiPAP machines are also very, very common. We in pediatrics use it only for those patients who are chronic, who are having some neuromuscular disorders with, as I said, intact reflexes, and those who need some sort of prolonged respiratory support, or those who are tracheostomized for some reason and is still ventilator dependent. So in those patients, we use the dedicated BiPAP machine, which is easy, which can be rented, which can be operated easily. We don't have to fiddle too much. Parents, patients also, attendants also can operate it at home. So in those, you use the NIV specific ventilator. So you can have what sort of interface you will have. So you can have a nasal mask, you can have a oronasal mask, you can have a full face mask, you can even have nasal cannula delivering the CPAP. So these are the interfaces, and whether how the safety. Sometimes if the machine for some reason is just not delivering, if you are putting a child with a very tight seal and the machine is not delivering, what will happen? the child will get asphyxiated. So there are certain masks with anti-asphyxial VAR. So you can use those also. So when you have a power supply which is erratic, you don't have a backup, or in home ventilation, that is more important. But we should be aware that there are this kind of valve available. Exhalation. So once the child is, we're delivering under pressure air, the child has to exhale. So you have either vented masks, or you have either, so you have either vented masks where a single tubing can be used. All the dedicated BiPAP machines, they will be having single limb circuit. So if single limb circuit is there, you are using that machine, you have to have these kind of vented masks, or these vented masks. Or if you are having non-vented mask, you have to have an exhalation port where the exhaled air has to go somewhere, right? So otherwise the child will not be able to exhale out. So either non-vented, the vented mask or non-vented mask with exhalation port has to be there whenever you are using a dedicated machine with single limb circuit. If you are using double limb circuit, you can use non-vented mask. That will be effectively delivering the pressure intended. So we chose conventional ventilator. Again, most of the common choice in PICU, because if needed, the same tubing can be used. So you don't spend on the circuit, and the machine already is there. You don't have to worry about having a standby ventilator, because whenever we are doing something which is intermediate care, we have to be always, it is more demanding. Somebody who lands upon ventilator, you tube the child, you ensure that the child is well sedated, the nurses will take care. Most of your job is already done. But if you are on lower levels of support, where the escalation is intubation, you are constantly monitoring, you are constantly worried that my child may not improve on this, or if there is still worsening, because this is the worsening has just started, the natural course is something like another 2-3 days, the child is going to worsen before my antibiotics kick in. You will be more worried about these children. Those who are intubated and ventilated, most of them, they are on auto mode kind of a therapy. We just have to see that things are all taken care of. We are appropriately titrating the ventilation. But here, HFNC or NIV, you have to be more careful. You have to be more aggressive in constantly thinking about anticipating the problems and dealing with them beforehand. So you have to have, if you are having a BiPAP machine, on that the child is there, you have to ensure that you have a standby ventilator, so that in case if the child doesn't tolerate, you have to go for the ventilation, invasive ventilation, and you have the ventilator ready. So we use the non-vented oronasal mask. So what are the initial settings? So either you can use CPAP or with pressure support, or BiPAP. And usually the EPAP, the expiratory positive airway pressure, which is like CPAP, around 4 to 5 to begin with, can go up to 8, depending on the child's, again, the child's condition. If you feel that the lungs are really stiff, you can start with even 6 or 7. But usually it is easier to start with a little lower pressure. The child gets accustomed to it, and we have to have cooperation of the child also in NIV, because it is a little threatening manner which we are doing. The whole face gets covered, or the oral and nasal cavity is covered. So the child cannot speak, so simply becomes very agitated. So we have to first ensure that we speak to the child, we explain, and we make sure that he understands that after applying this, he will feel a little better. And we do that. The inspiratory pressure starts at 8 and then can go around 10 or 12 also. You can have auto trigger of the inspiratory and expiratory modes, and you have a minimum backup, so that if the child is not really breathing properly, at least as a rescue ventilation, ventilator will do the job. So how do you see the effectiveness? So you increase every 5 minutes, 10 minutes, you increase the IPAP by 2 centimeters to achieve your target tidal volume. Usually 6 to 7 in any lung condition, 6 to 7 ml per kilo you will be targeting. So you ensure, and if there is not much of a leak, your expiratory tidal volume, which the ventilator shows, is the basically your volume. So you increase by that, and you also, as per your oxygen requirement and as per your saturation of the child, you increase the peak. So there is a limit up to what we want to go on NIV, because NIV is a intermediate level of support. So if you are needing more than 8 centimeter of EPAP and more than 60% of FiO2, that tells you that this is not working and we have to, go ahead with the next level of support. So this child was started on 50% of FiO2 with a PEEP of 5 centimeter and pressure support of 8, and the expiratory trigger was kept at 40%. And again, whenever you are putting any child on doing any intervention, you keep analyzing for the effectiveness or the failure of your intervention. So you do the same thing here also. You look for the comfort and adjust the interfaces so that there is no leak. The child is comfortable. Ensure that you apply some skin protection adhesives like deodorant around the edges of the, where your interface is, and ensure that the tidal volume, intended tidal volume, is being delivered. Ensure there is not much of leak. You have a leak compensation also. Ensure that there is a good synchrony with the patient and the ventilator, and you can see the curves as well. Clinical parameter, again, we have discussed the same thing here, and you look for the saturations, you look for intermittent blood gases. So blood gases per se doesn't dictate here anything, but it just tells us the effectiveness. You calculate your ratios of PF ratio and all, and OI, and you go ahead and you carry on. As long as the child is doing okay on these parameters, you carry on with the support. If the child needs more and more of oxygen and more of pressure and still not maintaining, then you don't spend any time more on that, and you quickly move to the next level of support, which is intubation. So after 4 hours, he continued to have desaturations up to 88%. We took care of all other things, mask fitting, everything was good. There's no leak. On 60%, child was saturating 88. The workup breathing didn't improve at all. Even the PEEP went up to 8, and the pressure support was 10, and the PF ratio decreased to 150. So this was clear indication that the NIV is not working in this particular child, and so we have intubated the child and started mechanically ventilating the child. So he was intubated with 4.5 size cuff tube, and meanwhile the art line was also processed. So whenever you are thinking about, so in intensive care, everything is about anticipation. So in anticipation, you have already escalated a level of therapy, then you prepare yourself, your team, and the child for the next level of supports. So if you are trying NIV, gather everything, have art line in place so that you can monitor the hemodynamics effectively, if you can do that. If it is not necessary, but need of inotropic support, use of bedside ultrasound, use of your clinical parameters, ensure that hemodynamics are well maintained. And if you feel now, then this child after 2 hours, he started having a little impaired perfusion. So by the time the parents got counseled and convinced that now intubation is necessary, it took that much 4 hours. But by that time, we already supported, because when you are a child with respiratory distress, when you are going to intubate, you are going to take out the sympathetic drive after giving the sedation and the paralysis. And that time only the child crashes, because so far the child's sympathetic drive was trying to maintain all the parameters. And once you do that, the child starts crashing. So you have everything ready. So you anticipate these problems before you intubate the child. So you start with inotropic support if you feel there is a perfusion issue, or you keep things ready to be started anytime. You make sure that the child's intravascular volume is full, is proper, it's not dehydrated or doesn't need fluid, because the moment you give your medications for intubation, there will be some vasodilation. Most of the medications which we use, they will cause a little bit of vasodilation. They will reduce your sympathetic drive. So all that compensatory mechanism on which the child was maintaining your stable hemodynamics, they are all going to get haywire. So we have to anticipate this and we have to be prepared for all these eventualities. So we started on mechanical ventilation with PRVC with a 6 ml per kilo of tidal volume, rate of 30 and FiO2 of 1, and then I/E of 1:2.3 and 8 of PEEP and 24 of PIP. So here we have a child who has severe pneumonia with ARDS, the septic shock is hypoxic. So what are our options here now? How do we escalate things further? We have already intubated, ventilated. We are on a little advanced mode of PRVC. You manage the etiology. If you have not got the source yet, try to have, now you're intubated, try to have a BAL, mini BAL. Get cultures, nowadays you have biofire, you have tests which gives you results within 3 hours, 4 hours. So once you know the etiological factor, you can address that. Most of these kids, they will have some sort of thin pneumonic effusion or empyema. So you have to take care of that also by placing ICD or draining it and appropriately managing that. Proning and positioning. So somebody, now this child has got the major lung problem was restricted to the lung. So here if proning nowadays has become a very useful strategy in even PICUs also. And in COVID, everybody started using it more and more. So people are more comfortable now, but depending on the unit. So if your unit is such that it is not yet comfortable in, you don't have that much manpower, you can at least have position. You can have the left lateral position where the left side is up, and you can at least achieve some ventilation with that. High frequency oscillators is very useful in ARDS in many cases. You have to be mindful about certain things. Again, the hemodynamics have to be taken care of. So that is something which is useful, and in very few cases, you may need nitrous and all if pulmonary hypertension is a problem, not in this particular child. And then ECMO is something, respiratory ECMO you have to do in children with ARDS. These ECMOs, VV ECMO will be a preferable method here because the hemodynamics are still okay. And in these kids, we have to keep counseling the family about whenever we are escalating therapy that we are doing this for this reason and we are going to use this. And what will be the next step? If we are failing, what will be the next step? If we are improving, what will be the next step? So that we make the parents ready for the next step, whether it is escalation or de-escalation. So they are constantly, they are aware of the situation, what is going on. Why is this not coming? All right. So you have a child with workup breathing. So if you have got mild workup breathing, you start with low flow oxygen, observe, monitor the child, face mask oxygen also is fine. If the workup breathing is increasing, it is not tolerating that, you might have to use the HFNC. So moderate workup breathing children, you straight away use HFNC. You can use NIV also. HFNC we say because it is, as I said, ease of use, now wider availability. So almost everybody will have this in the units. So once you see improvement, you carry on with low flow oxygen again. And if there is worsening or the child is having severe respiratory distress, then you have to mechanically ventilate the child, intubate and ventilate. And if the resistance and compliance is still not getting better, if they're getting better, you wean and you move to the either NIV or HFNC afterwards. And if they're not getting better, you can use little newer modes, you can use proning, you can use other strategies, high frequency, and then ECMO. So next will be Suman, who will be teaching you how not to look at the X-rays. Thank you very much. Any questions you have? You have there? Any questions? We have a workstation also on NIV HFNC because in this talk, we stressed more on these. because these are something which can easily be doable. Even if the unit where you are working, it is not having all the facilities, but these are some things every basic PSU also will be having. So we stressed more on NIV and heated humidified high flow oxygen. But any questions so far? Or we can have the questions at this session, work session also. Online किसी का question पूछे? Alpha.
ఫార్మాట్ మొత్తం మారిపోయింది. Hi. Can I have some attention? Sure. Right. I'm Dr. Suman, consultant pediatric intensivist in this branch, girls PICU. So today we are going to talk about X-ray. We have exhaustive sessions on work of breathing, then respiratory support. Usually what we see is most of the times we talk about ABG or someone tells about ultrasound or CT. So here I'm taking a chest X-ray. So, like CT or the MRI or an ultrasound has taken a very major roles in lung these days. The X-ray usage has come down very less. Though although we get it, but it's like nearly my teacher used to say neglected grandfather. But still, I'm talking about X-ray. Still, X-ray holds its fort. The reason being, I would say, the moment you want an X-ray, you can get just like that. You want to read the X-ray, you can just read the X-ray like that. So it is a very simple modality of understanding what is going with the lung. So a disclaimer, I'm not a radiologist, not a pulmonologist. I'll just tell what all you know, just refurbishing on things what you know. That's it. My format has completely changed. I'm sorry. Okay. So what we are talking. ఒక్క నిమిషం ఇది పాయింట్ pointer will not be visible over here. It's too bright. So what we are going to talk about next 30 minutes would be talking about the quality of the chest X-ray, basic anatomy of the chest X, basic anatomy that is involved, and secondly, a systematic approach. Fourthly, we'll be talking about few abnormal patterns and what are the tubes and lines in PSU that you can see in the X-ray, if possible, if time permits. There are nearly 130 or 140 slides. So I was keep on adding to whatever I've learned or whatever I was reading. I'll skip a few things. I'll not get you bored. So let's so my predominantly I've taken all this content is from one is chest X-ray survival guide. The other is Kefis Pediatric Diagnostic Imaging. These are the few references which I've made. ఇది కింద కనాలి. అట్లేదు. ఇది తీసేలేమా కిందది? Hide. Right, great, thank you. So we'll talk about the quality of the X-ray, right? We need to know, now at times you say underexposed, at times you say overexposed. How do you make it? See, if you see, ఇది చాలా కష్టం అవుతుంది బాస్, మూవ్ అవ్వట్లేదు. ఎందుకు మూవ్ అవ్వట్లేదు? Okay, see, this is what sort of film? This is underexposed or overexposed? Underexposed. This one, why do we need to know whether it is an underexposed or overexposed? So if you have an underexposed film, you will have a prominent bronchovascular markings. And if you see the diaphragm, if you see the left heart border, it is obscured. So you will be diagnosing more pneumonias without having pneumonia if you have an underexposed film. And if you take about overexposed film, you'll have increased translucency. Have increased translucency where you tend to diagnose over foreign bodies or what do you call pneumomediastinums, pneumothoraxis, if you are looking at this film. So you'll be having a lot of doubts about it. So hence you need to have a film which has got adequate exposed, right? So but considering the same thing, do we get overexposed films normally to see for any particular things? If you want to see the tip positions of ET tube or lines, that is the time you get an overexposed film to see the tip. So white structures, bony structures can be clearly seen in the overexposed film. That is the time you'll get an overexposed films. So how do you differentiate which is adequate, which is underexposed or overexposed? If you see, adequate film is where you have a clear-cut trachea being visible in the center, and the vertebral columns will be available. All the disc spaces also will be visible. Below this, actually, over here, you should not see the, what do you call, your disc spaces on the thoracic spine. So if you're not able to see clearly, then that is called an adequate film. The second, is it an inspiratory film or expiratory film? Again, does it help whether it is an inspiratory film or a expiratory film? Will it matter or is it matters? So what film you want, inspiratory film or expiratory film? Inspiratory film, right? Why you want to have an inspiratory film? To see the lung feels better, you want an inspiratory film. Do you get expiratory films particularly for any purpose? Yeah, if you are suspecting a foreign body, getting an expiratory film will have more translucence, and you can have that obstruction will lead to increase the translucence, so you can diagnose more better in expiratory film if you have a foreign body suspicion. Now, how do you differentiate inspiratory film or expiratory film? So for that, you need to know something called ribs. So there are two ribs, anterior ribs and anterior end of the rib and posterior end of the ribs. So you have to calculate your posterior ends of the rib. How to detect posterior ends of the ribs? So posterior ends of the ribs starts from this thoracic spine. The ribs that you're seeing, 1, 2, 3, 4, all these are starting from the thoracic spine. These are your posterior ends of the rib. Things which are not able to see the end point, that is called anterior ends of the rib. So in an inspiratory film, you have 9 to 10 ribs, nearly 9 to 10 ribs at the dome of the diaphragm. Whereas for the posterior ends, for the anterior ribs, you have nearly 5 to 6. So that is called an inspiratory film. If it is less than that, that is an expiratory film. So if you have, what is the problem? If you have an expiratory film, your cardiac shadow will be overly seen, and you will be diagnosed hypoventilated lung. You will say, at times you will say there is a left lower lobe collapse. You'll say such things if you have an expiratory film. That is the reason you need to know which is an inspiratory, which is an expiratory film. Right, now rotation part. So how do you detect? Rotation is also very important, right? Rotation. So how do you detect rotation? You have two ends of the clavicle, and the midway is your spinous process. So this spinous process should be in the center and should be equally distant from the clavicle, right? So if you're taking a picture like this, like an X-ray you are taking from this side, this patient is turning towards left side. Your clavicle is moving towards your left side, right? So if you see the X-ray, your clavicle, medial end of the clavicle will be moving towards left side. So you can see it over here also. Middle end of the clavicle moves towards your left side. This will be turning towards left. So that is how you're going to detect whether there is a rotation or not. Now, how does a rotation will help if there is a rotation or not? Or like if there is rotation, do you have any concerns with that? Your mediastinum will be shifted. You will have a false interpretation of mediastinum being shifted, hilum being shifted, or at times your left hemithorax, if it is shifted to left, this looks more translucent. And you will be thinking this could be a pneumothorax. So if you can correct those things, you can make a little better diagnosis based on the X-ray. So AP or PA view. So most of our pediatric X-rays are AP views, right? So does it matter whether it is AP view or PA view? How? See, the beam is coming through this side where the heart is very in a PA view, the film is more proximal for this heart. So you'll have approximation of this heart mediastinum can be better seen in the PA view. In AP view, there will be scattered rays where you'll have more enlargement of the heart. So hence AP view is not a ideal way of looking for the mediastinum or the heart. Now, how do you differentiate between PA and AP? There are many ways to say that, but I'll say very simply, normally you don't see your scapula border in the lung fields if it is a PA view. In AP, you'll see the scapula border. And your clavicles will be obstructing your lung zones in PA, not in AP. Simple way of telling. So normal X-ray, all the white lines you see in the normal X-ray have blood vessels. You don't see bronchi in the X-ray. You don't have pleural fissure. You don't see normally. You don't see fissures in the X-ray. Now lung zones. So we have lung zones and lung lobes, right? So apical zone, upper zone, middle zone, lower zone. Why we need to know zones rather than upper lobe, middle lobe, lower lobe? See, if you see here, this is right upper lobe. This is right middle lobe. If you see the right lower lobe, right middle lobe and right lower lobe are, if you see in the frontal aspect of the X-ray, both are coinciding. If I say there is a pneumonia over here, so if I say here pneumonia over here, is it right upper lobe or right middle lobe or right lower lobe? So it becomes difficult to localize where is the pneumonia. So getting a lateral X-ray will help you in identifying where is the localization. You have a right upper lobe, right middle lobe, and right lower lobe. So getting a lateral X-ray will help you in localization of the lesion. Same with the left lung. If you see, left upper lobe is completely giving the frontal aspect of the X-ray. Completely. So if you give, then you get a lateral X-ray, then you see the right upper lobe covers the frontal aspect. If you want to see left lower lobe, you need to get a lateral X-ray. So this is, you know what is silhouette? Silhouette is, many of them say silhouette sign, silhouette sign. Silhouette sign is not an abnormal sign. Loss of silhouette is an abnormal sign. So normally, without looking the actual person, looking at the shadow itself, you can say this is the picture of that person. That is called a silhouette, right? The silhouette is, so here the silhouette, you have a right heart border, you have left heart border, the dome. So this right heart border is found by right atrium, left heart border is found by the left ventricle. So if this silhouette being obscured by some pathology, that is called loss of silhouette sign. So based on the localization, based on the area that is being involved, you can say that part of the lung or that part is being affected. So suppose you have something called, this is a right heart border being obscured, right? You have our left heart border silhouette sign is obscured. Loss of silhouette sign of left heart border. The same with right hemidiaphragm, left hemidiaphragm. So this helps you in understanding the localization. The silhouette sign will help you in localization. So if you have a left heart border being this gone, So this numbering is gone. Sorry for that. So if you have left right hemidiaphragm, then you have right lower lobe being affected. So if you have second, if you have this, how do you call, fourth, this is chest spaces where this contour is being affected, then it is because of chest disease or pleura. If your aortic knuckle is no, this silhouette is lost, then it is secondary to anterior mediastinum problem, or it can be secondary to your left upper lobe disease. If your right heart border, not the mediastinum part, right heart border is lost, then there is something called, the problem is at the middle lobe, that is right middle lobe. So I'll show few x-rays of the same thing so that we can identify. So now coming to these are the basic anatomy, basic quality of the x-ray that you need to see. Now systematic approach. So you go by upside down, or from one point of lung to the other lung, zigzag, or you come from the center to periphery. You can read in any way, but it's always that you should not miss the important points. Most of the people have a tendency to read from the center to periphery. So what all we need to see if you have a X-ray being given to you? There are PGs here. Okay. So your teacher might not accept the way I teach or here. This is only for practical purposes. Now they have a different, I'll show how a teacher experts in your exam. So you need to see something, if an X-ray is handed out to you, you should see the patient information. Is it the right patient or someone's patient? You should see. There are many mishaps happened because of wrong labeling or assuming this patient, this X-ray might be some other person. Technical aspects, the things which I've told previously, you have to see something called trachea, lung lobes, and you have to see something called mediastinum, heart, then costophrenic angles, cardiophrenic angles, some bony structures and hidden areas. What are the hidden areas? I'll tell you. And the diaphragm. So you have to see all these aspects when when X-ray is handed out to you. So I said patient data, whatever, whosoever the patient, you should identification must be mandatory. Don't assume things. So don't ask me why I kept an elephant in this X-ray. So the reason I kept is you have to start, again said, this is not a for an exam purpose. You have to see your striking feature of the X-ray. So looking at all the aspects, I'll start my proceedings looking at the striking feature of an X-ray. This is what an examiner expects. So if you have a lesion, then the tissue involves size, side, number, distribution, position, shape, edge, pattern, density. These are the 10 aspects you would expect in an exam. So if you have, so X-ray is very simple. You have a white shadow or a black shadow, right? So white shadow, you label any word. You say opacification, you say increased density, increased whiteness. All the terms are acceptable. You choose whatever you wanted to. The point is you have to make out of it. So let's come with the systemic examination, the airways. This is the airway. So airways is shifting towards right side. Suppose this airway is moved to right side. Here that is problem secondary to thyroid. Over here, the shift towards right side is because of tension pneumothorax. Here, the massive pleural effusion is shifting the trachea towards opposite side. If you have a collapse or a fibrosis, the shift will be towards your side. This is a common entity that we learned. Now coming to the increased density or opacification or whiteness. So increased density secondary to, it can be secondary to consolidation, collapse, nodule or mass or fluid. These are the common 4 entities. I'll say you can fit everything into these 4, right? If you have decreased density, it can be cavity, cyst, or it can be new air. So let's go with the individual things. Like you have to see how the consolidation looks like. So you have a consolidation. These are bronchioles. These are alveoli, right? Here, if you see, the bronchioles have been affected. Few parts of the alveoli have been affected, not all the parts of the alveoli. Not complete alveoli has been in. Only partial part of the alveoli, not all the alveoli. Some alveoli are also been left. If you see, this is called airspace disease. If you see the X-ray for this pathology, you will see something called diffuse multifocal confluent opacities. They are multifocal reticulogranular opacities. if you see a consolidation, the entire alveolar has been involved and all the alveoli have been involved. This leads to something called homogeneous lobar or segmental consolidation. Actually, to say consolidation, to say these are the things which you call as consolidations, terminology wise, but we apply everything for everything. This, what is this? Air bronchogram. Normally you see the air bronchogram. Normally you see normally air bronchogram in X-ray. No, you don't see normally air bronchogram. It's already air, right? If it is filled up in and around the airway, if you see something consolidation, then only you'll see. So what the X-ray which I showed you. So bronchioles and part of the alveoli have been involved. That is called a bronchopneumonia. And how does an X-ray film looks like? If you see, they are involved in perihilar regions. Their granular appearance, non-homogeneous. They are not completely homogeneous. Predominantly in the hilar region and moves towards your periphery. This is how a bronchopneumonia X-ray looks like. Now this is homogeneous opacity. All of you agree with me, right? And if you see, you'll have, what is this? Air bronchogram. So I've showed different areas of involvement, right upper lobe, right middle lobe, right lower lobe. Looking at the lateral X-ray, you can make it. Same thing for left. Said air bronchogram. This is the air bronchogram that I'm saying. Interstitial, I will not cover. Now, this is how you make a consolidation. Now, the other important thing that you see commonly is atelectasis, collapse. So collapse can be secondary to occlusion, the bronchular obstruction because of your bronchiolitis, or it can be from extrinsic, where because of pleural effusion or pneumothorax, where you can lead to some extrinsic compression leading to collapse. So how do you see? If you see that this is a fissure, normally between the right upper lobe and right middle lobe, you have a fissure, right? So this fissure will be displaced and there will be gross opacification of the segmented collapse, right? So, and the other signs is you have your hilum being displaced, your mediation will be shifted, the volume will be less, and wherever it is involved, the cell out will be lost. This is how you make a collapse. I'll show you in the X-ray. All of you agree this is a collapse? You have a very sharp border formed by this is a fissure, right? This is a sharp border. You saw the loss of the volume and the ribs over here are crowded. So your hilum being shifted up or the mediastinum also shifted towards your collapse region. You see the other areas of the lung, these are little hyperlucence. And your dome of the diaphragm also bit elevated. So this is how you make the diagnosis of a collapse compared to what is called consolidation. Am I clear? Thank you. So, I'll say only important things. Now the same thing, I want to show about the left lung. So as I said, left lung, entire frontal aspect of the left lung is taken up by the left upper lobe. If you have a left upper lobe collapse, which usually you don't see, predominantly you see the right lung being collapsed. Left upper lobe collapse is a little uncommon way of presentation. So left upper lobe, if you have a left upper lobe collapse, you have entire diaphragm being opacified and shown as a white shadow because entire frontal aspect of the X-ray is being covered by the left upper lobe. If you say the lateral X-ray, then you will make it better. So this is about the atelectasis. So now lung fields are over. Now we are going about the pleura. So why we look for the pleura? Normally you don't see pleura. Why? What are the two reasons you expect for the pleura to see? One is a fluid, the other is air. These are the two things. So this is costophrenic angle, a bit obliterated. This is because of pleural effusion. Same thing, there is a bit moderate pleural effusion where you have a concave meniscus. This is also commonly seen. If you have a massive pleural effusion, entire lung will be shown as a white opacification. At times you'll get difficulty, either it is a complete pneumonia, what do you call it, pleural effusion or pneumonia. At times it can be both mixing together also. So the same lamellar parallel to the surface. This is encysted pleural effusion. So there is something called subpulmonic effusion. You know that subpulmonic effusion, where you have this lateral end of the diaphragm will be little elevated, and this what do you call stomach bowel also will be shifted down. The examples lamellar, you have encysted pleural effusion. Subpulmonic infection, as I said, you have this gastric bowel displaced a bit down, and your lateral end. Normally, you will have this middle end of the diaphragm be elevated, but in subpulmonic effusion, you see this lateral end of the diaphragm being bit elevated. Not really important actually. Now coming to supine. So in the same, if someone is having pleural effusion and you see it on the supine position, you see the fluid is layers out in the, it forms a layers. Entire opacification has been, you can see that. That is the reason you'll have little difficulty in comparing with consolidation and pleural effusion in a supine position. Pneumothorax, a large pneumothorax can be recognized from very far distance also. The problem comes up with a small, what do you call, very small pneumothorax. I'll show you. See, in supine position, basic problem comes with if there is in supine position. If the air collects predominantly in the anterior aspect of the region, anterior region. So if you see, what do you call, best area to see small, what do you call, pneumothorax would be juxtacardiac regions. This is the region. What is this sign? Anyone knows what is this sign? Deep sulcus sign. So this diaphragm sulcus will be tinted downwards. So there will be wide, very wide and deep costophrenic angle, deep sulcus sign. This is how you can make, this is a real. So normally if you don't see this, you will miss out this pneumothorax. Large pneumothorax easily can be found out. If you have a small pneumopocket, then you see the juxtacardiac regions. There you have a deep sulcus sign. So there is something called double diaphragmatic sign. There is something called tension pneumothorax. Again, it's very easy to detect. You have a clear-cut collapse, and this will be shifted towards your mediastinal contents will be shifted to opposite side. It's easy. Probably difficulty comes when the child is having an ARDS type of pneumonia. Then the difficulty comes actually. Hydropneumothorax, we all know you have both water and the air. Heart, I'll not go. Again, this completely different. Mediastinum also, I'll skip off the major aspects. You see, this is anterior mediastinum, middle mediastinum, post mediastinum. You have different structures involved in this mediastinums. Based on the involvement, you can figure out which part is being involved. Can someone detect what is the problem here? Does anyone say this is the, all of you agree this is only thymus? This? 2 tiles of thymus? No. I'll show you. This is how your sale sign that everyone says, thymus. Normal thymus sign. These are the different variations of thymus you see in X-ray. So there is something called angel wing sign. This will be air under them. 2 wings. This is actually the picture is this. Angel wing sign. If you have an angel wing sign, there is a pneumomediastinum. These are the areas usually we miss. Apical areas, hilar areas, retrocardial areas, and a zone below the diaphragm. Bones and soft tissues. how to speak about a normal chest X-ray. Like you'll say, what view, is it inspiratory or expiratory? With what exposure, adequate exposure, no rotation, trachea is central, lung fields are clear, normal bronchovascular markings, cardiac celerity is maintained, mediastinum is within normal limits, pleura, costophrenic, cardiophrenic angles being maintained, no soft or bony tissues being involved. This is how you will label someone as normal chest X-ray. So we are heading to the end. So this is normally, this appears to be little hyperinflated on your right side initially. So you suspected some foreign body, you get an expirator film, then lucency will be increased. That's how you make a diagnosis of foreign body in X-ray. This is not a classical X-ray. We are not talking about a classical X-ray. We are talking about something very doubtful, suspicious. That is the time you're going to get this. If you are still in doubt, you will go and get a virtual bronchoscopy done where you can figure it out. Fluoro will help you in identification. So the bronchiolitis part, we know the chest will be hyperinflated. If you calculate the number of ribs, it will be 9 to 10, more than 9 in your post ends of the rib. And you have, this is very important, streaky perihilar infiltrates. These are the streaky perihilar infiltrates because of bronchiolar involvement. What is this? I'll just tell only the elephant part. Agreed, this consolidation collapse. Does anyone say it's a consolidation? Sharp, margin is very sharp. Dome of the diaphragm is also lost. Dome, right hemidiaphragm, a low silhouette is lost. It's right lower lobe collapse. Can someone say what is this? Pneumatocyst. Yeah, it can be cyst also, but you have a pneumonia over here. So, cyst, like this is a pneumatocyst caused by staphylococcal pneumonia. These are multiple pneumotocysts. Last, since I'm an intensivist, I'll talk about lines and tubes. Can someone tell this line position is okay? How many are not happy with this line position? Everyone is happy. Huh? You're not happy. Okay. Someone else not happy? See, this is IJV line, right? Right? Where should be the IJV line tip? Where? SVC. Okay. So if it is for left IJV, so you place left IJV or right IJV, SVC is only one SVC. So your tip should be in the SVC. IJV, right side IJV, left side IJV, the tip should be in the SVC. In between right atrial junction to the SVC. So this is easy to tell in this picture. If you want to tell me in the X-ray, you have a second intercostal space and there is something called carina. In between the two, you should have find it in and around here. This would be an ideal place for both your right side IJV as well as left side IJV. So is it okay? This is a PICC line. This line, this X-ray. Where is the tip? It's in the right atrium. You'll continue with this line or you want to do something with this line? It's okay. Already we have placed without a lot of difficulty. I've placed. You continue the same thing, you'll have arrhythmias. This is also deeply placed. Can someone see this? This is very funny. Where the subclavian line which you have placed is going up into the IJV. So this is a PICC line, I guess. This is a PICC line where it is going into the IJV. You continue or you take it out? You take it out. You don't continue. This is chest tube. Can someone say what is the problem with this chest tube? What is the striking abnormality that you see with this chest tube? Someone, please. Very striking abnormality. Right, it is not in the pleural space at all. It is in the chest. The main problem that we face while we are placing a chest tube is you have that based on the chest tube you are taking, you have 2 to 3 holes. At times you have 4 to 5 holes also. Make sure that all holes are being inside the pleural space. At times it happens, you have taken a bigger one and you've kept 3 inside and 4 are inside and 1 will be outside. The entire air will be going back. The purpose is not maintained. You are going to deteriorate the child. Make sure when you're getting an X-ray, just into the pleural space does not help the serve the purpose. You should make sure that all the holes are within the pleural space, right? Here you have all the holes. Actually, this is a bit bad film, but you have all the holes within the pleural space. ET tube. So, where should be the ET tube? Is ET position is okay? Not okay. Okay. This one. The tip, if someone can't identify, I'll show you. This is the tip position. Okay. Not okay. High, low, okay. Or say something. It's high. Okay. How about this? It's almost went into the right lung. See, it's a right lung intubation. Do you have a left lung collapse because of there is no ventilation to this? So where should be the ideal ET tip position? Below the carina, above the carina. How above the carina? Above the clavicles. So there is something called middle end of the clavicles and the carina. In between both the middle end of the clavicle, midway, that should be better. Some textbooks also mentions 1 centimeter above the carina, but I always follow above the carina and between the middle ends of the clavicle. Now, as I said previously also, can someone say what is wrong with this X-ray? Only striking abnormality. Tell me only the elephant part. Don't start from the tracheostomy point. Both right and left. So I'll tell you. Right side pneumothorax or bilateral pneumothorax? Only right side, not left side. Hyperinflated, na? Translucence. Still, you say this is not left side. This, I think, this should be clear. You have a collapse here, a clear-cut collapse. Here, you don't have a collapse. The reason, what is the problem with this X-ray? The quality of the X-ray is not good. What is this? It is an overexposed film. Since you have an overexposure, the left lung, which has to be normal, has shown you as can be a doubtful pneumothorax. Right. Clinically, if you want to make a decision, that point of time you will be little worried. Am I right or wrong? Is it only unilateral or bilateral? So after placing an ICD, then I got the X-ray. Now you see any pneumothorax on your left side? No. Is the position of NG is okay? Where should be the NG position? See, if you are placing for gastric decompensation or feeding, it should be in the stomach, right? If you say, no, you don't have particular point for everyone because pediatrics is from 1 month to till 18 years. So you can't say for adults, you say from gastroesophageal junction, 10 centimeter from gastroesophageal junction, but it is not like that. For us, the tip should be in the stomach if you are going for NG. Plus. Any questions? I know it's like it can be a little boring. I am fond of ultrasound, but still I think reading about the X-ray, making a presentation for myself, it helps. X-ray is something which is really neglected. If we can use properly and if we can read as many times as possible, you will make multiple diagnoses and you have your experience with X-ray will be much better. So if no questions, then we can conclude. No questions, right? Fine. Now, after this, we have stations. So we'll have a tea break, then followed by stations. So we can divide into 3 stations. So we'll say 1, 2, 3. From here you say 1, 2, 3, 1, 2, 3. We'll say the numbers so we can divide the stations. Right. Up. You speak it, you say it loud. You should remember your numbers, okay? No, three stations. We have only 3 stations. Two, sir. Okay. I think this is very stressful job, na? अरे मेरा number कब आएगा? 2 बोलना है 3. After T will divide the stations. Once T is done, once the stations are arranged, I'll tell where to go. Okay. Right. Thank you. happy with the child's breathing pattern. Breathing pattern is asynchronous. Child in respiratory failure. The consciousness also being affected. So this is a respiratory failure. Here you will intubate or you will try with something else. Intubation. So here at this point, so we have clear indications for intubation. We have respiratory failure, we have a hypoxic respiratory failure, we have respiratory shock, we have something called cardiorespiratory failure. Then you intubate. You have a low GCS, fall in GCS. Right? These are the indications for intubation. Now, all of us know how to before intubation. Simple intubation is you want to intubate a child. What is the important aspect of the intubation? Preparation for the most important. Last running for different aspects. Keep all the equipment that are needed for your anticipate that there is going to be a problem. There is going to be a problem. It can be a difficult area in the terms of stomach. There can be a difficult in the terms of physiology. Normal intubation, regular intubation, you want it. Keep always ready for intubation. What are the things that you need to do? Planning is open plate of appropriate size. You want the intubated infant. Which plates you want curved or straight? It's better to have straight plates. The child age is bigger, then curved bed so that your tongue falls. I have done for 1,000 skill fail. So preparation for intubation is the most important thing. Let's talk about the preparation. Before that, we should also know that what are the indications for intubation. I'll show just a brief video. You say whether you want to intubate this child or not. Okay. So that is also important, right? The clinical decision at the bedside taker if you intubate or not to intubate. I think Dr. Parakar has told clearly. If you're having a doubt, you intubate. I probably it doesn't hold everywhere. Like you just entered the ICU, not just seen a child, little doubt. You have to go with certain numbers also, right? So, and clinical well-being of the child also. I'll just show you video. The time up there, na for the. This is a baby who has came to here, an infant on NRM. You can see the child having grunting, retraction, tachypnea. Right? You saw this child. Now, completely. The child is on NRM maintaining 100% saturation. So not only the numbers which will decide, we know numbers is not something which will decide for the intubation all along. You have got multiple other parameters. Now tell me among this group who wants to intubate this child. On NRM, child is grunting, child is having tachypnea, retraction. Who wants to intubate this child? You want to intubate this child. Anyone here? You want to intubate this? You want to intubate this child? Anyone else? So to intubate or not to intubate, first we'll go with a little stepwise. Is it a respiratory distress or respiratory failure? Failure you're saying. Okay. Does anyone disagree with that? Someone is having tachypnea. Is usually someone is having tachypnea, subcostal retraction, intercostal retraction. You'll say that someone gives tachypnea, that is respiratory distress. To the respiratory distress, someone's consciousness being affected, someone's hemodynamics being affected, someone's GCS being affected, or your hemodynamics being affected.
you're having not maintained number on good percent of FiO2, then you'll say respiratory failure. Your number is maintained with 100% FiO2, you're maintaining 100% attrition. The child is opening the eyes and looking in and around. Is this just maintained? There is a consciousness being not maintained. So and most probably your hemodynamics are also stable. This is a respiratory distress. It is not a respiratory failure. So someone is having respiratory distress, you have a chance to start on other modes of ventilation, like non-invasive modes of ventilation. You use the HFNC, you can use the CPAP, right? So we can use HFNC or CPAP for this patient. Since it is a respiratory distress, I'll not intubate this child, giving a trial of probably non-invasive modes of ventilation. At the same time, you'll keep yourself ready for intubation. As such, this is not like respiratory distress, you don't intubate, just keep HFNC or NIV, you go home or you go to tie break or anything, you don't come and see the patient. If you're starting on NIV, make sure someone is at bedside and be monitoring the child whether the child is going into respiratory failure. I'll show you the classical example over here. So I've started on NIV for this patient. You can start HFNC also. I've started on NIV. So how many of you agree this is okay? Pattern of breathing is okay. Does anyone disagree? The child is, can we say this NIV being tolerated well by the child? Right? All of you agree? Right. So pattern of breathing. I'm not looking at the numbers, sir. I'm just looking at the way the child is breathing. Child is very comfortable in this NIV. Right? This is an NIV being successful. The same child after 3 to 4 hours, look at the pattern of breathing. The same child, you started on NIV, the child tolerated really well, and you're probably we thought like why we thought of intubation, like we thought of intubation, but see the way the child is breathing. The same child, you started on NIV a couple of hours or back. Now see the pattern of breathing. See the consciousness of the child. Child is looking up, it's not looking in and around. The consciousness being affected, the way the pattern of breathing being affected. This is a respiratory failure. This is an NIV failure, right? And this is the point you intubate the child. So coming back to the old question again, what are the indications for intubation? So someone said low GCS. So low GCS and around less than 8 or equal to 8. Or if there is a drop in GCS by 3 points, where you can consider intubation electively to secure the airway. We have definite names for that. One is you said, what do you call low GCS, neurological purpose. Respiratory purpose, we label something. Respiratory failure, right? Respiratory failure. So, and cardiac failure or cardiorespiratory failure. You intubate. Same child, in the initial video, child is having respiratory distress and child also had shock requiring inotrope. May not be fitting into a cardiorespiratory failure at that point of time or respiratory failure, but someone is having respiratory distress and shock requiring inotrope. I would intubate this child. Intubating the child, you are going to provide oxygen, decrease the muscle usage, decrease the oxygen consumption, and you are going to give more oxygen that will help in stabilizing your shock. So these are the classical indications for intubation: a respiratory failure, cardiorespiratory failure, cardiac failure, or a respiratory distress with shock. And neurologically, if GCS is less than 8 or less than or equal to 8, or drop in GCS by 3. These are the indications for intubation. Right? Now, you thought of intubating the child. Now, what is the first discussion that we had is what are the difficulties that we are going to face during the intubation, and we have discussed that most important difficulty is preparation and anticipation for yourself for the intubation. So you have to keep everything ready. You have to keep everything ready for intubation. Let's discuss what are all we need for intubation. We'll start from you. what are all you need for an intubation. You have different soap me, you have different things for mnemonics to remember this thing. We'll go step by step. What are all things you need for intubation? You want to have a pre-oxygenation. Okay, pre-oxygenation, fine. You need to have a bag mask, which is an appropriate size. If you are using for an infant, you use for the pediatric. If you are using for a neonate, you use pediatric. You will see neonatal bag. If you are using for adolescent, you will use adult. Mask also age appropriate mask. I will not discuss what sizes of masks are here. Next. Laryngoscope blade, which is of appropriate size. If I'm using for an infant or neonate, I'll try to use for a straight blade. If I'm using for little older age children, I'll try to use a curved blade. Reason, you want to fix your base of the tongue onto the curved blade. So blade size is according to this. Third, she said about ET tube. So commonly used ET tubes are cuffed ET tubes, right? So we have different formula for calculating. You calculate and decide, and you took ET tube. So you choose one ET tube and you will choose one more ET tube, which is 0.5 size external. You will have definite difficulty while intubating. This is very theoretical, but once you face this, then only you will be able to understand. So next, want to have a suction, right? Suction. Next, medications. I'll say it's a medication. So we'll discuss the medications about little later. Okay. Next, ET fixator. Okay. Saturation monitor, you're saying monitor. Anything more? Fluid bolus and inotrope. That is another content. About the medications and fluid bolus and inotrope will combine together. We'll talk about the medication. Anything more you wanted to know? You wanted to have while intubating a child? So you do bagging. Sequence of steps. You do bagging. You take out. You clear out the suction. You clear out the secretion with the suction. Then you use laryngoscope blade appropriate. Then you place ET tube. Then after ET tube being placed, how sure you are about the ET tube being placed into? You have to have an identity checkup, that is like clinical way. Do you have another way of confirming the ET tube is been? We have one way is looking at the mist. Have a mist, clear visualization or a mist. You'll think in the terms of it is being placed. You do bagging. You have a good chest air entry. You'll say. There is very important thing, something called ETCO2 caliber. So ETCO2, if you have that maximum, that is becomes your job very easy. Now, the moment the reason why I'm telling you is, however clinically you are strong enough at that point of time, in that terror moment that we are facing at the second, and saturations are not picked up for some reason. Maybe intense bronchospasm was going on, intense fluid was there, where you're doing bagging. Your bagging was not appropriate. Maybe your bag was not good, or the feed that you are providing to that patient was not sufficient. That is the reason the saturations are not picking up. And but your thought process for that point of time will you only think probably my technique of intubating the child. Probably the tube was not in situ. That is the reason saturations are not picking up. There may be a number of reasons. It can be failure of this. The PEEP was insufficient. Maybe the child might be having extensive fluid in the lungs. You need higher PWs. Probably you need something called vein circuit. But you will not think of those aspects. You will think probably I have intubated. I have not intubated rightly. That might be. You have a tendency, probably I'll take and I'll try to intubate. The moment you take that step, you're gone. So hence, if you have an ATCO2, that makes our job easy. If you are clear that you have a miss, you have a clear that it is in situ, then you keep on doing. It is not rapidly falling. I think you can keep on doing the bagging. So sometimes, like if you're not picking up, take out the ET tube, many people say. But if you have an ATCO2, that makes our job really comfortable. This is what one point which I want to tell. So anything more that we wanted to, once you confirm the ET tube, then you connect to the bag and mask and you connect to the ventilator tube. That's all. Now let's talk about something called medication. Medications, fluids, and inotropes, right? So, so what are the medications that we need to intubate a child after the adrenaline? So you give adrenaline for every patient before intubating. But you will keep things ready for adrenaline. Considering the child can go into cardiac arrest. Next, what medication? You need to tell your sister that these are the medications I might be requiring for intubation. You already set the equipment, right? Now you're taking about the medication. You're saying fentanyl. Fentanyl. Okay. Next. He said adrenaline. Same. Inotrope. Next. Muscle relaxant. Anyone have a different anything else? She said what is it? Adrenaline, inotrope, and she said fentanyl. She said muscle relaxant. So I'll actually, rather than telling the name of the medicine, I'll tell you the three things. What do you need for intubation? Hello, madam. Hello. Hello, madam. What do you need? There are three entities that you need for both intubation and both for ventilating a child. You need something called a sedative, which will relieve the head as a very uncooperative patient. You should keep the child calm. You should break the anxiolysis. You should provide some sedatives. So what are the sedatives we know? Midazolam and lorazepam. Even Dexpert is also a sedative. Probably, but for intubation, I'll tend to use more of a midazolam or a lorazepam. I tend to use more of a midazolam. It has got only sedative properties. It does not have some other rest of the properties. What is the next medication type of medication that you need for intubation? Before muscle anesthetics, before anesthetics. You don't give anesthetics for all the children. One sedative, other is analgesia. You need to provide something called pain relief, analgesia property. The third you wanted to have is a muscle relaxant. So the three important medications, type of medications for both the procedures like intubation. The secondly, you want to for ventilated child is sedative, analgesia, and muscle relaxant. So what are the what do you call medications that you use for analgesia? Ketamine, fentanyl, morphine. These are the three common drugs that have been used. If you ask, most commonly used is ketamine, followed by fentanyl, followed by morphine. Usually we don't use morphine as a procedural sedation, but no, you can use it. Muscle relaxant. So what are the muscle relaxants that we want to use? Atracurium, vecuronium, rocuronium. Succinyl choline is something which is not commonly used in pediatrics. We can use. Doses I'm not telling you. You have to check always before you give the dose. Keep on practicing, you'll be able to remember this. Now coming to the fluid boluses and inotrope. Why you need a fluid bolus or an inotrope? I'm just asking you, does we give regular glycopyrrolate? Does we give regular atropine? So in infants, probably a vagal stimulation can lead to bradycardia, where that is a time where you can have an atropine bedside being ready. Don't give a prophylactic atropine. That is not something. What's the third thing we're taking about? Inotrope and the fluid bolus. Why you need that? Why you get shocked when you're intubating? Per se, the child's hemodynamics were bad before, so while you're intubating, that can further get down. Reason? Normally, your hemodynamics are maintained during that stress phase because of sympathetic stimulation, right? All your sympathetic drive gets lost when the moment you give something called sedative. All the sympathetic drive will be lost. And if you give muscle relax, it causes vasodilatation and it will cause further hypotension, right? So the second important physiology that is being involved is if the hemodynamics are good, but still while you're after intubation, you'll say यार intubate करने की पहले ही अच्छा था, intubate करने के बाद और collapse हो गया. The thing is, you something called a positive index pressure. The moment you're giving through a bagging, it will compromise the preload circulation that is reached to the heart. You have a high PWP inside the lung. So far, the volume of blood from the periphery is coming to the lungs and to the heart, predominantly your left heart from the right heart. So if you have high pressure, the input will be compromised and go into the shock. That is the reason if you are intubating the children, you will be keeping yourself ready with a fluid bolus inotrope. So this completes our preparation for intubation, right? keeping all the equipment that are ready and keeping medication ready, keeping fluid bolus and inotrope ready. This is for a regular intubation, right? What if you have something called a difficult intubation? I'll go into the technical part. As I said, for me in intubation, the technical aspect is the least concerned part. Anyone who has intubated twice or thrice can easily intubate, right? If yourself are kept ready for all the situations. Now I'm telling you, there is a difficult airway. Difficult airway is not something like I'm facing difficulty, hence it is a difficult. Right? I have certain things for saying that is a difficult airway. There is something called anatomical difficult airway, a physiological difficult airway. What is an anatomical difficult airway? Any anatomical abnormality is causing for you to difficult, making your intubation very difficult. Your abdomen is so bloated, or your there is a tracheal abnormality, laryngeal abnormality, there is a retrognathia, or your microcephaly. You're not able to intubate. Your larynx, as I said, unit form, larynx being very higher up. So these are the few aspects where you can have anatomical difficulties. So if you are not prepared for that anatomical difficulties, whatever there might be anatomical difficulty, your anticipation, looking at this child, you can anticipate this is an anatomical difficulty. Am I not wrong? So you see there's small mouth. You expect there can be subflutic sound. You can expect the tube might not go into the well. There is some syndromic child. You can expect high vocal cords, high vocal cords. So your anticipation, then you'll keep something ready for a difficult intubation. What are the difficult intubation? We'll discuss later. Right? So what is a physiologically difficult airway? Physiological difficult airway is someone is having hypotension, respiratory failure with hypotension, cardiorespiratory failure. The moment you intubate, the child is going to collapse. Your intubation should be very brisk and smooth. And you might be feeling bad, but definitely that point of scenario, you should involve someone who has got a good experience in intubating compared to less intubating. You should not take into the terms of ego at that point of time. If you have a better person, better experienced person, you should give to the other person. Both are equally, then you can go for it. Physiological difficulty airway, where your hemodynamics are being affected, or you have a significant raised ACP, where if your intubation is not smooth and you are going to try it multiple times, it's going to damage the brain and it's going to further worsen the ACP. So these are the few scenarios. You'll have a physiological difficult airway. This was a physiological difficult airway. You don't have much time over there. The moment you miss on one step, probably I'm telling you, the child will collapse. You have cardiac arrest. I think most of you have seen that scenario. So if you are prepared for those aspects, you'll be able to do intubation. The technical aspects of the intubation. This mannequin is anatomically difficult. Something problem with this. I'm not able to see the vocal cord. Trying to figure out. I'm calling him, but this is difficult. It's not the vocal cords itself are not seen. But you can just try on looking how is it. All of you have acquaintance with the laryngoscope blade. Looking at this, I'll just show you. Someone can show. Can you show me how to do bagging? So if you are facing difficulty in intubation, right? You're trying to intubate once, not then you tried twice, it didn't happen. Keep on. You tried third, it didn't happen. You don't have any other better person than you over there. What will you do? Keep on doing bagging. Bagging is as good as equal to bag and tube. Don't wait for something or just you are so much worried that you're not able to do bagging properly, then it becomes a difficulty. But it is not raising. Bagging it is working. For intubation it is a difficult airway, but for bagging it is there. Classical example of probably difficult airway. We'll manage this difficult airway. Good, we'll manage. Okay. Okay, little bit grazing. Something is wrong. Probably you can do something else to make this airway better. You're doing bagging and you're not able to insert the chest. What else will you do? You'll reposition, right? You'll reposition. You'll do suction. You'll make your little bit little bit extended. Then you make your heel of this mask very well, and then you do the bagging again. Probably your oxygen is not connected. That is the reason it might not be getting. So proper calculation. Don't anatomical different error. So you make your neck should be little extended, not hyper extended. You'll cover both the nostrils and the oral structure. You make a tight seal with your seal, and you'll keep your rest of the fingers onto the mandible, not onto the neck. What we know. Now, little bit hyperextension. Then you'll see the chest rise happening. So if you are getting good chest rise, the saturation will pick up. If you're not able to intubate, you keep on doing the same thing. As I said, this is an anatomical difficult airway. What else we can do over here to intubate this child, to ventilate this child, apart from bagging? Tracheostomy. Okay, tracheostomy. Before that, do we have anything? You can use LMA, right? This is an LMA. You have different sizes. You have a 0.5, 1, 1.5, 2, 2. You have different sizes of LMA. This is Dr. Alekia, pediatric intensivist, is working with me in that school. So we have a LMA. Do you know how to place LMA? How do you place an LMA? How do you place? You apply the jelly onto this part. So there is something called a C-shaped point, which is cuffed and open. You place such a way that this part of flat area will be going like this, and you'll place it. This is new one. They'll charge me. Right. So basically, what is your point is, you saw this, right? This one should be coming onto your vocal cord. That is how. So this point, you'll be placing like this. You'll be applying jelly over here. Then you will place like this. Okay. Jelly, any jelly you can, lignocaine jelly. So right. So you have not placed this one. Any other way you can intubate this child? Still, rather than still, it is used for ET tube inside to maintain the contour of the ET tube. But nasal intubation is also the same intubation. This, you know, what is this? This is bougie. This bougie, how does it help you? You don't need to plaster this one. The problem is you are having a difficult airway. You are seeing the vocal cord, whereas your ET tube is not able to pass through. So what you are going to do is you are going to pass your bougie through this vocal cord. Once the bougie is in situ, then you will pass the ET tube through this. It will go in. Since bougie has gone, even your ET tube also will go. Right? This is one thing. Do we have an idea about this? This is a video laryngoscope. So you can visualize the vocal cords very well. So it comes like this. Firstly again, 2.5 lakh. This is an adapter. This you have both tunneled and non-tunneled. So where you keep like this. So with this it is difficult. Sorry. You can do from that. You can see, you can appreciate. vocal cuts కనపడాలి చెప్పే కదా ఎకనామికలీ డిఫికల్ట్ బట్ యూ కుడ్ సీ అంటే కింద ఏమున్నదని యూ able to see in the video, right? Now looking at this, you'll see the vocal cords. How you place the ET, right? Your vocal and you can be sure that the vocal cords are you are placing the ET tube through the vocal cords. Right? This is about video laryngoscope. We talked about Uzi. We talked about video laryngoscope. Do we have anything else? Okay. Someone said tracheostomy. Can we do tracheostomy? What all we need for tracheostomy? You need a gray color cannula and a 10 ml syringe filled with water. This is a cannula. Cannula I can open. Super. You will take water. You will fill with the syringe. Then just because you will see the cricoid cartilage. This harden. You puncture it. You puncture it and you drag with the syringe. Then you will get the bubble. Once the bubbles are there, that means you are inside the trachea. You are in the trachea. Now take out the skillet. You have an adapter, ET tube adapter. You take 3 or 3.5 adapter, 3.5. You fit to it. Do the bagging. The moment you are entering, like the way you place for center line. So once you are getting the bubbling, that means you are in the trachea. You don't need to go further. Remove it, connect to the adapter, and do the bagging. So this is something which we can do at the bedside, rather than going for tracheostomy, cutting and all this. This is an easy process. And this is not a permanent procedure. This is something where you are in a desperate situation like this, where you don't have any other option. What will you do? You should do something tracheostomy, ideally. Before tracheostomy, you can do cricotherapy till your ENT surgeon comes. Once he comes in, this is a temporary phase. Like you use intraosseous time. Use it for temporary. You don't do it for a day or something like that, right? So this is a basics of intubation and difficult intubation and difficult scenarios. So just wanted to ask someone like difficult intubation, you have different scenarios. The medication side which you need to avoid. I said someone is in hypotension. I'll try to avoid a benzodiazepine. Right? I don't use propofol. Someone is in hypotension. Anything more? Raise recipe. Somehow this concept is gone. We have our own. When I was in PG in 2012 or something like that, we had ICP catheters being placed in the study, and ketamine has been given as an infusion, and there is no rise in the peak of the ICP. So the study well proved that ketamine is not going to increase the ICP. You can use ketamine. Negative inotropic. In fact, it maintains hemodynamic health. It can have a negative inotropic effect also. There is too much details, like say, I don't know, but ketamine is something which it's a hemodynamically stable drug. Most of the times we can use in most of the scenarios. Will not try some unless too many secretions. Someone says like too many secretions, it increases secretion. To do suction, you want to avoid ketamine. This is about the basics of intubation and difficult intubation. Anyone has questions regarding this under discussion? You see the prominence, right? This is the prominence. The prominence. Before that, you find something called C-shape. Just find those. Rather than measurement tapes can lead to cricoid cartilage also. You see the thyroid prominence here. Just below the thyroid prominence, you see something gap over here. There is a gap. There is no chance of gap left. Where you find the C-shape things, where you can puncture exactly like that. Any questions? Good. Okay, I'll be going now, madam.
Sorry, what are you asking? Okay. Okay, okay, this one. Okay. This nearest. Okay, okay, okay. Huh. No, no, I mean, tube is connected. It's a long tube. I mean, like 15 centimeters distance. It's a proper delivery of the aerogens, whatever the nebulization we give. If it is very nearer, there will be a dispersion. It will not go down to the patient's airway. If it is very far, that will be always in the tubing only. It will be diluted. If it is very nearer, it will be dispersed. It will not go down. So that 15 centimeters is the ideal thing. Through research and all, like all the papers and all, we that is the ideal place where we have to connect as per the case reports and all, which was experimented and all. Okay. CPAP. You finished that station, right? Okay. Bubbles.
This is not bubble. Conventional ventilator.
CPAP mode of ventilator.
So that is not bubble filter. It's a continuous positive airway pressure. When you are not eating any weight, this becomes diagonal and this is delivered by the ventilator, by the conventional ventilator. That is what we meant. But done. हम तो वेट कर रहे थे हमारा नया बैच आएगा. Here you don't have to bother much. Expiratory trigger, you have to keep present 40%. When is the expiratory triggered? Once you reach the 40% of the temperature, it will be triggering the that's what is there. The main parameters are those are the main parameters. The safety parameters are backup, like if the child is not breathing. So what is the rate? 25, 20, depending on the child age and all. And what will be the backup rate item? What will be maximum vector? Those are the technical.
Which one? Actually, we don't have that chamber. There is a specific humidifier with the nebulizer thing. We connect through one connector here. We don't have that. Actually, that is directly connected and we do that nebulization. Yeah, this one. See this. So this is the specific nebulizer which comes. This is the specific humidifier with the nebulizer. We get it. We don't.
You have to
remove and give.
Or some people will, because every 2 hours I have to remove the. So that's what, if your level is more, even if you carry on with that, because we are using the ground at 50% of this. So there is still space for the tube to go in. To reduce the flow momentarily by 1 to 1 liter per kilo during the time of nebulization. And remember to switch back to your earlier flow after the nebulization is over. You can still use that because the child will keep mouth open.
You can put it maximum flow.
Reduce the flow and
So, okay, fine. So let's discuss about HHFNC. What this is? Heated, humidified, high flow nasal cannula. So this is the machine. How do you connect this? This is the humidifier, and we have we connect with that. Actually, this is the tubing. We have this, no? Yeah. We don't need to say that. Okay, please connect. Come. Ulta better. This is the patient side. Other thing. This is to the distilled water for the filling. This will be filled till here. Okay, and this is the connection here, and this one is to the patient's interface. Okay, so there are a lot of interfaces here. I mean, interfaces to be sorry. Any pieces around? There will be color coding actually. Mostly, this is based on the nail size actually. So usually XS, S, M, L, XL will be there, and red and yellow usually we use for the infants and neonates, and purple color, this is for bigger children around 4 years till 4 years and all. Later green, and these two are for the adolescents, obese and bigger kids who need more flows. Okay, so this is about the interface. So how do you connect the what is the method? I mean, like what is the principle in connecting this interface? So your interface prongs should be fitting at least 50% of the nest. It should not be more than 50% because there should be recirculation of there should be some amount of the leak. So the nails after connecting that, and what is the advantage of HFNC? It provides, so you have listened to the talk in the morning, no? Okay. Okay. Yeah. Yeah, splinting of the upper airways, and some amount of positive pressure will be provided. Other thing is it removes the dead space, and humidification is another advantage, so that it will not dry the secretions, and crusting and all will not be there, and thickening of the secretions will not be there. Other thing is humidification is one of the biggest advantage compared to the normal nasal prong oxygen. There will be drying, all will be there. And how do you start this HFNC, with how much flows? So less than 10 kg, 2 liters per kg. And that too, it depends upon the patient. I mean, like if you start 2 liter per kg, the child is almost like less than 10 kg, 8 kg, 16 liters, you don't start straight away. You need the child to acclimatize to that flows. Otherwise, that child will be very cranky, and maybe that work of breathing will increase initially. So 2 liters per kg for less than 10 kgs, later about 10 kgs, 0.5 liter per kg. So that flows, what are the things you monitor after you start, and after how much time you need to reassess after starting HFNC? Ideally 2 to 4 hours. So this, all the HFNC and non-invasive ventilation, all the things, you need to be at the bedside to reassess the things. But in the ventilated cases, you just ventilate and you can sedate the child. You don't need to need continuous monitoring like that. So what are the things you need to see? Work of breathing, heart rate, respiratory rate, saturation, and you can take a basic blood gas, one blood gas. If you don't have a blood gas, you can monitor with the SF ratio, saturation to FiO2 ratio. So oxygenation, you get that, and your work of breathing, whether the child's work of breathing is getting better or not, that one you need to. And heart rate and respiratory rate, it should reduce at least by 20%. So if the child you don't clear the total disease process immediately after 2 to 4 hours, whether the child is settling or not, or child is calm with that thing, you need to see. And everything you need to, if the child's heart rate is going up, work of breathing is increasing, before judging that it is a failure of HFNC, first you need to look at your interface, whether your interface is proper or not. Your nasal prongs are very tight, and if you have, what if you have chosen a bigger nasal prongs, which is not appropriate for that? And any secretions, did you clear all the secretions? Other thing, any other significant wheeze is there, you need to nebulize or not, that one you need to see. So you need to clear the secretions, wheezing, and nebulization, and your whether the prongs are kinking, like child will be moving a lot, and your nasal prongs will be towards the lateral wall or towards the bridge, and it's not delivered properly. So you adjust everything before labeling that child is a failure on HFNC. You need to, before thinking of the escalation of the respiratory support, you need to see all these things. And what are the conditions we use HFNC commonly? Bronchiolitis, mild to moderate pneumonia we use, and other things, asthma also use. Okay, so what is the nursing care you take while doing while the child is on HFNC? What are the things you need to see? Yeah, humidification is proper or not, and too much whether water condensation part, is the temperature set correct or not? If the temperature is not appropriate, there will be inappropriate condensation. Other things, yeah, 37 temperature, you can set the temperature. These are the knobs actually. This is the on his tara. So other thing is you need to have an orogastric tube because there'll be a lot of gaseous, there can be a lot of gaseous distension. You need to decompress the stomach. Other thing, this beyond this interface, these wires, there may be child will be on that. So you need to check for the pressure source and any block here if it is very tight, and secretions. Secretions also intermittently you need to do suctioning and all. So these are all the things you need to see. Okay, the honor work pen, no? No. This is the alarm. Actually, this is the power. And other thing, after you use this machine, this circuit, this interface will be disposable one. I mean, one time use only. But you can still use the circuit, autoclave and that. After the machine is used, you have a red color tubing for the sterilization. So it is set at a particular temperature, 75 degrees around. So you need to sterilize for at least 1 hour after we use this. So this is to change this. You need to double press to unlock. Okay. So this is increasing the flows. Okay. So going to next, this is FiO2. FiO2 you set by increasing the flows. Okay. So to unlock this, you have to do that. That's the thing. Temperature, you can, temperature is around 34. I mean, 1 second. Okay, actually temperature set is 37 degrees. Ideally 37 degrees is the correct thing. And this FiO2 you set by increasing the flows and this flows. Maximum you can go almost like, even suppose there is a condition where child is, you have increased the flows, FiO2 around 40%, still child is having increased work of breathing. So maybe before seeing everything, you need to adjust all the interface as I have told you. Later, you need to see what if you are giving correct flows or not. So don't keep on increasing the FiO2. First, increase the flows and see that. And before that, is there any acute worsening? Like is there any severe bronchospasm? First, nebulize. So there actually for nebulization, there'll be another humidifier with an inbuilt nebulizer. So so there is a separate humidifier with the inbuilt nebulization. You can even give with nebulization through that. So which is especially exclusively for this HFNC. So you can even nebulize. So otherwise, if you don't have that humidifier with inbuilt nebulizer, you have to remove and give with a nebulization. I mean mask. There's mask and normal nebulization we can use. Okay. Anything? Shall we move on to NIV? Okay. So, yeah. Other thing is after 2 hours, when you feel that child is having increased work of breathing, still respiratory rate is more, heart rate is increasing, then after checking everything, if the disease process is worsening or child is having impending respiratory failure, you need to escalate the respiratory therapy to ventilate. I mean, you need to intubate ultimately. But if the child is recovering, so you can, ideally some people say that you need to reduce only FiO2 flows. You can directly stop it. But every 6 hours you can reduce the FiO2 by 10%, 5 to 10%, and flows you can reduce by 2 to 3 liters, 2 to 4 liters. So if suppose it's 30, 25 liters we are using, so if the disease process is getting better within the next 6 hours, you can reduce by 5. So flow slowly you can come down. So you can come down even to till 2 liters. You don't need to switch to nasal prong oxygen. We can use the same interface and change to 2 liter oxygen, and then you can come to room air also. Okay. That is, I mean, every 6 hours you need to reassess, and you can gradually reduce the flows. Even for a smaller kids, you have to reduce that nasal till 2 liters. But bigger children, asthma with 1 to 2 days, I mean, the child came with severe wheezing and all. You can wean off very fast for that sort of kid. It's like only within 24 to 48 hours. Even on 10 liters, you can come down to 5 liters, and you can remove that also. So only for the smaller kids, you need to taper it slowly. Okay, right. Maximum upper limit beyond 60%. If you are requiring FiO2, it means that child requires intubation. Okay, not only provided it should not be erratic that you have increased too much FiO2. That's why you just start with 35 to 40% and slowly increase, go up till 60%. If you initially start at 60% and then see that child is improving, but child may be stable initially with that 60% FiO2, but after that child may deteriorate. You don't have that window time of assessing. Okay, right? So NIV, what is NIV? Non-invasive ventilation. It's the positive pressure ventilation we give without putting the tube inside. Okay, so non-invasive ventilation usually. How do you approach the child? So did you listen to the talk in the morning, Eisman algorithm? So according to that Eisman algorithm, what are the indications? I mean, you need to identify the child, identify the patient, and identify the type of respiratory failure. So what is the type of respiratory failure? Whether it's type 1 or type 2. Type 2 is alveolar hypoventilation, like asthma, bronchiolitis, or other things, some neurological issues also. Other thing, type 1 respiratory failure is pneumonia without hypoventilation. Pneumonia, mild ARDS also you can use. So identify the who is the ideal candidate for starting NIV. So it means like contraindications. What are the contraindications? Who are the patients in whom we don't use NIV? Yeah. Poor GCS, altered sensorium, hemodynamic instability. Other thing is oropharyngeal, any issues, craniofacial anomalies like cleft lip and all we don't use. Other thing is craniofacial trauma, and the child with lot of secretions, they may not tolerate NIV. You need to clear the airways frequently. They're not the ideal candidates. And uncorrected pneumothoracic failure, there is no question of NIV. You need to intubate the child directly. Another thing is recent surgery, any gastric surgery or any gastric surgery, because there will be lot of aerophagia, abdominal distension. They are not the ideal candidates for NIV. So identify the patient. Contraindication, equipment. You need to know about the equipment. What is the equipment you use? So equipment all contains the mask. Where is the mask? So equipment contains the interface, tubing. Other thing is ventilator. So is it a standalone NIV equipment, or the NIV equipment connected to the mechanical ventilation? So this is the newer, advanced thing, mask, which is very soft silicone material, and there are grooves here for the NG tube without causing any pressure and all. And is this a vented mask or non-vented mask? There is no exhalation port here. Usually, non-vented mask we use for a ventilator thing, because we have a dual limb. So expiratory and inspiratory limb we have. Expiration port, expiratory limb is there. We can use a non-vented mask. This is for the ventilator thing. Vented mask we use for the standalone machine, NIV machine. Standalone NIV machine with exhalation port, we use it for chronic lung disease patient with the home bypass machine and all. So settings do differ in the standalone machine and on the ventilator. See, this is the mask. Usually, this is the oronasal mask. Okay, this is fitting like this, and you have this total straps and all back. It will come. So there are we do have other interfaces, but they're all in the working condition. We don't use this. This is the advanced thing which Fisher Packer people have provided. There are other masks also. So sometimes to prevent the pressure source, usually when you connect this is very soft. There are less chances of pressure source with this. But usually we use deodorm or hydrocolloid dressing for the to prevent that pressure source and all. Okay, so tubings and all. This is the ventilator thing. So we have the modes here on the ventilator. See, this is the NIV mode. NIV mode. So the mode settings. Usually we set pressure support, PEEP and SiO2. Ideally like till 60% we can go in this. And expected trigger usually not beyond 40%. So trigger is at the 40% of the breath cycle, it triggers the expiration point. Ideally, by default, we set around 25 to 40%. Okay, remaining all the inspiratory trigger, we don't need to set this. Only these are the main settings. Okay, so this is in the ventilator, we have this settings. If in the standalone ventilator, standalone NIV machine, we have IPAP and EPAP. Okay, IPAP, EPAP, rise time, and the modes will also be different. Chronically home ventilated patients and all. So in that Iceman thing, so usually we start with the less pressures, and as per the tolerance, we step up this, because suddenly if we put a higher pressure and that flows, and sometimes there will be claustrophobia and all, child will not tolerate that much flows. Slowly, once the child acclimatizes to that mass, slowly we tend to increase the pressure until the requirement. We need to see the chest rise, everything and all. Okay, and work of breathing, how the child is doing on that. And if possible, we can sedate. We can as well sedate with a low dose dexmedetomidine, to calm the child. Okay. Only disadvantage with this is there will be lot of aerophagia, because other things compared to HFNC, on HFNC we can feed, but on this we can't feed in between, and also secretions and all suctioning. If the child is requiring frequent suctioning, we need to remove and do the suctioning and all. Other thing, aerophagia. So we need to decompress. Actually, OG tube you can put and decompress the stomach. So other thing is pressure source. So you need to take the interface out and remove intermittently every 6 hours. You need to check for the pressure source, whether the strap is too tight or whether it is loose. If it is loose, there will be a lot of leaks. It will not be effective and all. So after connecting to the NIV and all, when to assist? It's same like HFNC, 2 to 4 hours. Whether your increased work of breathing is increasing or your heart rate is going up, respiratory rate. So, but at the same time, you need to check the interface. First, readjust your interface. You can try with some low dose of sedation. And that interface, they should not, that mask should be appropriately fitting. There should not be any leak in the other thing. And you can as well give nebulization with this NIV also. There will be 2 limbs, inspiratory limb and expiratory limb. Inspiratory limb, there will be aeroflow nebulizer, round one with a connector. This is the inspiratory and expiratory limb. So this is the patient side. This is the patient side, and this is the inspiratory limb. So from the patient end, there with one more connector, we put that aero neb. Okay, aeroflow neb, approximately 15 centimeters from the patient end of the inspiratory limb. If it is too far, that aerosolized particles will be inside the tube only. If it is too near, there will be dispersion in the cavity near the oropharynx and all. It will not go down the airway. So with the interface only, we can give the nebulizations also. So when you consider after 2 to 4 hours, you adjust the mask, everything, you see whether the interface is proper, and then decide whether child is a failure or NIV or not. So if there is impending respiratory failure, your disease process is worsening, then you need to step up your escalation of your therapy. Okay. In that Iceman, what is the other thing? M is the monitoring mode. What is the mode? I already discussed this pressure support in that ST mode, and what are the settings and all. A is analysis. Analysis, you analyze based on the everything, your PF ratios or SF ratio, saturation, FiO2 ratio, and it will be clinically based on the work of breathing, your heart rate and all, monitor pulse oximetry, saturations, and other thing is ABG, other thing. So based on that, you analyze. N is what is the next step. So whether you need escalation or you need to continue. If the child is going better, doing well on that, slowly based on the X-ray, your clinical parameters, everything, you can slowly step down on the pressure support. Okay, and we finish before time. Huh? ఏంటి అందులో మోడ్ ఉండాలి, ఎన్ఐవి మోడ్ మన దాంట్లో ఉంటది, అంటే మనం చూసుకోవాలి. కొన్ని దాంట్లో ఎన్ఐవి మోడ్ ఉండదు, సర్వో ఐ ఉంటది. సర్వో ఐలో ఎన్ఐవి ఉంటది, సర్వో ఎఫ్ లో ఉండదు. స్టాప్ చేయాలా? తినలేదు. ఇప్పుడు నేను పరిగెత్తాలి. మధ్యాహ్నం పొద్దున వాళ్ళు మధ్యాహ్నం వస్తారు. స్టాండ్ బై.
ventilation. So when the basic respiratory mechanisms fail, which will either cause hypoxemia, where is oxygenation failure, or ventilator failure, there you will require respiratory support. So briefly regarding the lung physiology, we will discuss about only one or two things. Lung complaints, as we all know, lung complaints is the change in the volume per unit change in the pressure. So lungs which are complaint, they require less pressure to have a adequate tidal volume, whereas lungs like a pneumonia lung, ARDS lung, which the complaincy is less. That means to understand like something like a duster. So when something is filled in, like if you have water in it, so the force required to contract it will be more, something like that. So whenever the compliance is less, you'll require more pressure to cause same amount of tidal volume. There are two things. So the definition is delta V by delta V. So change in unit volume due to the change in the pressure. It has a static compliance and dynamic compliance that will not go into details of it. And the second thing is the resistance. Resistance is like whenever like in a ventilated patient, we are giving air from externally. So we have the airways. So we have the large airways, medium airways, and small airways. So their airways have a resistance which will oppose the movement of the gas. So that is the resistance. So it is defined as the amount of pressure which is required to the generate a specific flow. The definition is that so pressure change to cause a specific amount of flow. So which will be defined by like this. And these two things. So most of the pulmonary or non-pulmonary pathologies will be affecting one of these things. Either there is a change in the compliance in pneumonia, drowning, all those things, or there is change in resistance. And third thing is a normal lung ventilation, like CNS causes, where their child is ventilated because of seizures or because of surgery. There the lung as such is not affected, but we have other causes for ventilation. So subsequently, so we'll move on to so how many of you have used ventilator. So we know we have mix of students here. Some are who are doing PG, some are post PG. So all of you have used a ventilator at any point of time, or some of you have not used. So as we see, most of you have used a ventilator before. So briefly about, so whenever we say ventilator, there are multiple things. The details regarding the type and mode of ventilation will be discussed in the next class. So briefly, we have 4 or 5 parameters which we have to know that these are the parameters which are the main things which will affect the ventilation delivery. So as we can see here, the mode of the ventilation is there. So different types of modes are there, which we will discuss in next classes. And we have the oxygenation, how much oxygen we are giving, the pressures, rate, inspirated time, positive and expirated pressure, support. Then we have the graphics, and these are the loops, and we have other parameters. So ventilator has multiple things, so which we should know at least in detail to begin with, so that we will be having a better idea to how to set these ventilator settings. So the basic ventilator parameters. So these are the basic ventilator parameters which most of the ventilators will have. Some will have 1 or 2 up and down, but mostly these will be there. So tidal volume is the one of the main thing, because 2 types of ventilation we will have. One is a pressure control and volume control. So in volume control, it is the volume which is the primary parameter which we set. So we have tidal volume, peak inspiratory pressure, plateau pressure, positive and expiratory pressure, and the rest of the parameters. So these are the basic parameters which will deliver the required breath. And we have other parameters like which will cause like beginning of inspiration and changing from expiration to expiration, which are called phase variables. This is a trigger, cycle, and limit. And then we have alarm limits. So that I will discuss later. So any ventilator, whenever you set a ventilator, you should never forget to set alarms, because it is a safety feature. Apart from that also, if your alarms are not good, the delivery of tidal volume, the delivery of the peak pressures may not be appropriate if alarms are not set properly. So briefly regarding the modes, so we have different pressure control, volume control, and hybrid modes. Based on the patient characteristics, somebody who is paralyzed will give a controlled ventilation. Who is having some efforts will give assisted and spontaneous breathing. Then tidal volume is the amount of gas which moves in and out of the lungs, which is breath. So we have inspirated tidal volume when you're talking about ventilator. So and expirated tidal volume. Both can be different. Why they can be different? Can anybody tell? If you're giving a 100 ml tidal volume to a patient, expirated volume can be low. So why is it so? No, residual volume will be anyways there. No? So normally whenever you're giving some PEEP, some residual volume, some FRC will be there. So in case of leak, if you have a leak, so that's when it is important. If you're giving a tidal volume of 100 ml and if you're getting out only 50 ml, that means something there is a leak, whether it is a peritubal leak or your connections are not good, or sometimes the filter problem. So that you have to see. So normal tidal volume is 8 to 10 ml per kg. tidal volume is the one which primarily affects, one is the chest rise. So chest rise is the one which we can see clinically, and the ventilation, that is CO2 elimination. The CO2 elimination is dependent upon the minute ventilation, which is defined by tidal volume into respiratory rate. So tidal volume is a parameter which primarily affects this thing. And whenever you set a tidal volume, you have to select based on the ideal body weight. Example, some child may be obese, like overly obese. He may be like 100 kg, 80 kg, but child is only 10 years old. So at that point of time, it is better to use ideal body weight rather than the actual weight, because the growth of the lungs is basically age and height dependent rather than the weight dependent primarily. So in obese children, then we have to better to go for the ideal body weight for the age, and we have to set the tidal volumes. So here we can see, so this is the pressure control mode. So we can't set the tidal volume directly. So when you set the pressures, then you will have the delivered tidal volume. So you can see this is the inspirated tidal volume, which is 190, whereas the expirated tidal volume is 140. So there is some difference. And in graphics you learn, you can find that leak here also. So tidal volume is one of the important parameters which you have to monitor regularly, because it will primarily affect the oxygen. In a way, it will affect oxygenation also and ventilation. Then next parameter is the peak inspiratory pressure. So it is the maximum pressure which is recorded during the respiratory cycle or breath. And in pressure control ventilation, it is the parameter which you set. So this is the pressure required to overcome the elastic and non-elastic components of the respiratory system to deliver a breath. And so whenever you are set a ventilator, so this one you can say this is the inspiratory pressure. This is on and above the PEEP, positive and expiratory pressure. Some ventilators are there like Drager, where this is itself is the absolute value. So if you're setting 8, it will give only 8. It will not give 8 plus 5, 13. Here we can see it is a 8 upon 5. So total peak pressure is 13. Some ventilators will have PP separate and this PIP separate. If you want to set 10, you have to set 10 only, not like 5 plus 5, 10. So each ventilator you should be aware. So my ventilator has this kind of function. So accordingly, you have to adjust. And if you are setting a pressure control, so there you can set the pressures. If it is a volume control, you can't decide upon the pressure. Their pressure is dependent upon, in volume control, basically the lung characteristic. Example, if you to deliver 50 ml of tidal volume, normal lung may take only 10, 12 pressure. A medium pneumonia child may take a 15 pressure. ARDS lung can take a 20 pressures. So it is about other parameters, inspirated time, respirated, because that will affect the duration of inspiration. So then plateau pressure. Can anybody tell what is plateau pressure? So there is one PIP, there is one plateau pressure. What is the difference between the two? If you see the guidelines, most of the time they talk in terms of plateau pressure. So plateau pressure is, as we discussed in the previous slide, so peak pressure is for overcoming airways and the lung parenchyma. Plateau pressure is to overcome only the lung parenchyma. You are not taking into account the airway resistance. So plateau pressure is the pressure required to maintain the lung inflation in the absence of the airflow. So that measures only the pulmonary parenchymal component, and typically it is measured in volume control mode with an inspiratory pause. To measure plateau pressure, we need a pause. So this one the schematic representation. So here we can see the maximum value is the PIP. Then you give a inspiratory pause. Whenever there is a pause, then the flow will be constant. At that time, the pressure which is measured is the plateau pressure, and that will be the pressure which is required to actually overcome the parenchymal resistance. So this picture you can see, so there are two kinds of scenarios. So here the difference between the PIP and the PEEP, and here it is the same. So in conditions where it is lung complaints is affected, so their PIP will increase and P-plat will increase. Whereas in conditions like asthma or bronchiolitis, where your only airways are affected, lungs as such parenchyma is normal, there your PIP will be much more higher than the plateau pressure, because the main problem there is the airways. So whenever you are handling those situations, if you put an inspiratory pause and see, if compared to the baseline, it is increasing and the transairway pressure is that suggests it is a primarily airway pathology which is causing the problem. So then is the frequency of the rate. So it is the number of breaths which we have to give to a patient, because so in pediatrics is a wide range. So we can see these are the wide normal ranges of respiratory rate. So for a child like 3 months, if you set a rate of only 15 or 20, that will not be sufficient, because his physiological rates are around 35 to 55. So you have to, depending upon the age, child is like mota less than neonatal age, infants 1 to 5 years, and after 5 years. So you have to have a rough idea of the basic physiological rates, and your settings have to match with that. And whenever you're setting the rate, inspirated time, I ratio, these are like kind of together. So some ventilators give you option to set inspirated time, and some modes will not give that option. You have to set I ratio and rates. So that will decide the what is the I time. So inspirated time is the amount of time given for the inflow of gas into the lungs, whereas it is age dependent. So we have rough normal values. Newborns will have a value of around 0.3 to 0.4 seconds. Infants 0.4 to 0.5 seconds, 1 to 5 years 0.6 to 0.8, and more than 5 years 0.8 to 1 seconds. Adults we can use somewhere around 0.9 to 1.1 seconds. If you set too low for inspiratory time, what will happen? So obviously, so the child is, for example, child is spontaneously breathing. So he wants to take it for 0.5 seconds, but you're stopping the ventilator at 0.3 seconds. One is he'll fight with the ventilator. There can be asynchrony. And to deliver the same tidal volume in a shorter time, you need a higher pressures. If you have to give 100 ml in example 0.5 seconds, you require a pressure of 15. If you have to give same 100 ml in a time of 0.3 seconds, your pressures will increase. So setting this age related settings is very important because that will prevent your asynchrony. It will help in smooth delivery of the settings which are given. And expiration time is for the expiration, and the I ratio, which is a ratio of I and E time. Normally it is 1:2 to 1:3. This is important mainly in case of obstructive airway disease, where you want to keep your expiratory time more than the normal thing to facilitate better expiration. So inspiratory time is primarily known oxygenation. So low TA will cause PAP will increase and MAP mean air pressure may decrease. And whereas expiratory time is primarily involved in CO2 elimination. So this is one the screenshot we can see. So in this ventilator, you can set rates and you can set IE ratio. You can't directly set the I time. So once you set rate and adjust IE ratio, then you will be able to see here the exact TA how much is there. So depending on the clinical condition, you need to change the settings. Then positive expiratory pressure is the pressure in the lungs which is present at the end of the expiration. So normally it is around 3 to 5 centimeters of water. If you set low, what will happen? If PP is very low, what will happen? A collapse. So in basically alveoli like balloons. So if you're completely taking out pressure, so it will completely collapse. And then when you have to give next breath, it will again we need more pressure to open it up. So you should never set pressure PEEP like something like 0 or 1. So physiological PEEP is 3 to 5. Depending on the clinical condition, you may set 4, 5, and in case of ARDS, you'll set it higher. So this is the PEEP set. Sorry, it is not visible. It is a PEEP setting. So in the pressure volume graph, so you can see the baseline is not at 0. You can see the flow is starting from 0. So you can know what is the PEEP set from the graphics also. So whenever if you set it 5, it will be here. If you set 10, it will be somewhere here. So if you set 0, the graph will start from 0. And FiO2 is one of the important parameters which will affect the oxygenation. So normal room air is 21, and we have ventilator we can give from 21 to 100%, and it depends upon the primarily the clinical scenario. If you're ventilating a normal lung child, you may not give much more than 30 to 40%. In pneumonia, you have to give higher percentages. Then pressure support. So what is pressure support? What is the difference between PAP, PLAT, and pressure support? So pressure support is like PAP and all. It's like it's a basic parameter. Like ventilator, you will give pressure of 15, it will give. So depends upon whether the patient is breathing or not. Either it will give without synchronization or with synchronization. Example, a patient is taking 30 breaths, but you set only 20 rate. So 20 rates it will give, but the rest 10, what will it do? If you are not setting anything, ventilator will give, depending upon the patient demand, it will just open the inspiratory valve and give free flow of mixture of oxygen and air with the percentage, FiO2 percentage, that will patient will take. But if you give some support during that extra breaths, the 10 breaths, you give some support, so patient will have a better tidal volume. So that will help him in better compliance and better oxygenation. So pressure support is the one which is like a PAP only, but it is given to those extra breaths which are not mandatorily given, and the patient is spontaneously breathing more than the ventilator thing. So those are things where you set pressure support, and it augments the tidal volume and decreases the work of breathing. So this is the parameter you can see, pressure support. So in some next few classes, you will tell how to identify pressure support, like in the graphics and all. So if you're setting a pressure support, generally it is set at 2/3 of the total pressure. Example, if your total pressure in this setting is 8 plus 4, 12. So you'll set somewhere around like 5 plus 4, 9. So it is around 2/3 to 3/4 of the total peak pressure which you are giving. Example, if you set it same as PAP, then it will be like all breaths will be of similar tidal volume, similar things. So the graphics, you will see everything same. Because if the patient is breathing or the ventilator is delivering, the pressure given and the volume delivered will be same. And mean airway pressure, it is the mean pressure recorded during the respiratory cycle, and it is dependent upon the P. This is the formula. It depends on PAP, TA, PEEP, and it primarily affects oxygenation. So you cannot set it. You have to. It is a derived value. So based on the parameters we set, ventilators will give. So here you can see the P mean pressure is 5. So those are the basic ventilator parameters. So you have seen 7 to 8 parameters. The primarily which affects oxygenation in general is MAP and FiO2. MAP itself is dependent upon PAP, PEEP, and TA. So if you have to target oxygenation, some child is not maintaining saturation, either you increase FiO2 or you increase PAP. In a way, tidal volume. If you're increasing PAP, you are increasing tidal volume, or you increase PEEP, or you give more time so that your expiration is longer. If I time is more, your MAP will increase. So these are the parameters which primarily affect oxygenation. And for ventilation, 2 things: respiratory rate and tidal volume. For pressure control, you can't set directly tidal volume. So you have to increase pressure so that you're giving more tidal volumes. That will automatically cause more minute ventilation and ventilation. And as I told, alarms. So alarms are one of the most important safety feature whenever you're adjusting a ventilator. So different kind of ventilator, different kind of settings. So this is an option where you have alarms. So almost most of the parameters we will be so we have some parameters like PP, minute ventilation, all those things. So you need to set according to the clinical condition, how much, what to be set, so that your alarms are not, they're not continuously troubling you. And if some mishappening is there, like if ventilator is not delivering, you should not miss that. So there's some guidelines. If your PIP should be like low PIP should be 5 to 10, and the high PIP 10 centimeter above the current set parameters, PEEP and all those things you can see. So if you are starting a child on ventilator, so what are the parameters, like what will be decided, what is the thing which decides what kind of parameters you have to set? So first thing is what is the indication for mechanical ventilation? Normal lung, or a diseased lung, or obstructive airway. So your parameters will change accordingly. And the experience of the team with the modes of ventilation. Some doctors may be comfortable with the pressure control, some may be with the volume control, you have to see, and availability of the different ventilators at your place. So these are the indications. So we have various scenarios. Depending upon that, you will decide which kind of mode you will use and what are the parameters you set. And the ventilator which we have discussed already. And we have various ventilators. Each ventilator has different working kind of technology, different parameters. Sometimes terminology may be different. So you need to be aware of all those things. So in volume control, mainly the tidal volume you set. Pressure control is the pressure you will set, which we will discuss in the next presentation in detail. So in normal lung ventilation, for a 10-year-old child, these are the rough kind of ideas. So 10 kg child, so 8 to 10 ml per kg, so around 8 ml per kg. Physiological rates, TA of 0.6 to 0.7, PEEP you give 4 to 5 centimeters, FiO2 to begin with 30 to 40, and you can decrease as tolerated. And volume control, you measure PAP, and pressure control, you monitor volumes delivered. So in ARDS, this we will discuss in later in detail, separate workstation is there. So you will try to give a little lower tidal, not the very low tidal, because the recent guidelines have changed that. In previously we are using much lower tidal volumes. Now somewhere around 6 to 7 ml per kg. You will try to give more PEEP because you want alveolar recruitment, and you will begin with the higher oxygenation because child is very sick. You can't start at 21%. You'll start at something like 60% or 80, then you will titrate. If you're using pressure control, you'll go with a pressure of starting with 12 plus 6 or 18, something like 18 to 20 PIP. PEEP of 6 to 8, and accordingly we'll see. Whereas in asthma, as we know, so it is the expiratory problem. So whenever you're using a volume control, you want to decrease little bit of TA and increase the expiratory time. So normal IE ratio 1:2 to 3. So we'll put 1:3 to 4. Depending on the ventilator, either you set the rate and TA or you set rate and IE ratio. So that depends on the ventilator. And give a lower PEEP because there are already air trapping is there. So you don't give normal PEEP, slightly in the lower PEEP. So depending upon the mode, you'll see. So to summarize, so basically we have to have a basic understanding of the lung physiology and the clinical condition. A child may have only airway problem or a parenchymal problem or both, or a normal lung but requiring ventilation. Basic terminologies in ventilator, we should be aware of them. And normal parameters in various age groups we should know. And our settings, the initial settings will be based on that. And depending on the clinical condition, we have to decide. And whenever we set a ventilator, you should not forget alarms. Alarms are the safety feature and we should appropriately set alarms. Thank you. Any queries, anything you want to ask? So we'll have workstations there, like we'll show what are the settings, how to do. So if anything, theoretical discussion, anything you want to ask? Now we'll go to next presentation.
Hello.
Very good afternoon all. So I am Dr. Avinash Reddy, pediatric intensivist from KIMS CUDDLE, Kondapur. And today in this session, we shall discuss about basic modes of mechanical ventilation. So before going to the basic modes of mechanical ventilation, we shall discuss briefly regarding the variables of mechanical ventilation that controls and determine the mechanical ventilation. So there are mainly two variables, that is control variables and phase variables. So the control variables determine in what way the breath has to be delivered to the ventilator. To the patient. So the breath can be delivered by giving the pressure, by giving the volume, or by giving the flow. And coming to the phase variables, they determine when to start inspiration, when to start expiration, and when to end inspiration, and when to limit the pressure as well as the volume. So that is what it determines, these phase variables. We'll see in brief regarding these phase variables. Just a second. Sorry. So these are the phase variables. So this is a pressure time scalar. So we'll see regarding this first phase variable, trigger. So basically the trigger is of two types. It can be machine trigger or the patient trigger. So in machine trigger, so usually the ventilator will trigger the breaths in a time dependent fashion. So in a regular intervals, the machine will deliver the breaths. And coming to the patient trigger, so whenever the patient who is connected to the mechanical ventilator tries to breathe, so there will be the negative inspiratory pressure which develop in the ventilatory circuit, or there will be changes in the flow which develops in the ventilatory circuit. These changes in the flow and these changes in the negative inspiratory pressure is identify the ventilator, and this will be identified as a trigger, and then the breath will be delivered. So the machine controlled control trigger will be commonly seen in the control modes of mechanical ventilator, and the patient trigger is commonly seen in the assisted modes of mechanical ventilation. And once the breath is triggered, so there will be the opening of the inspiratory valves will occur. So once the inspiratory valves will open, so the pressure will build up and there will be pressurization seen. So this pressure will increase to a certain extent, and then after that the pressure will be limited. So there comes a variable called as a limit. So there is a limiting of the pressure is seen. So what exactly the limit does is it determines the magnitude of the breath. So how much pressure has to be given and how much volume has to be given to the patient. So it ensures that the delivered pressure and volume is not above the set limit. So usually the limit in volume control mode, it is a volume targeted and volume limited. And in pressure control mode, it is a pressure targeted and pressure limited. And once the limit is reached, so once the limit is reached, so there will be the inspiratory time which is preset in this any modes of mechanical ventilator. Once this inspiratory time is done, So till this point, there will be the opening of the expiratory valves. So when this inspiration ends and expiration start, this is called as a cycle. So cycle is the one which will determine when to start expiration. So after desired I time is set. So the cycle usually determines like when to start inspiration and when to start expiration and when to end the inspiration. So it is in time cycle mode. It is seen in the pressure control mechanical ventilation, and it is like a flow cycle in case of pressure support ventilation. And it is a volume cycle in the volume control modes of mechanical ventilation. And based on these phase variables, these mechanical ventilatory breaths are classified as follows: mandatory breaths, assisted breaths, supported breaths, and spontaneous breaths. And in mandatory modes of mechanical ventilation, the trigger, cycle, as well as the limit, all three is from the machine itself. And in assisted mode of ventilation, the trigger is from the patient, and cycle as well as the limit is from the machine. And in supported modes of ventilation, the trigger as well as the cycle is from the patient, and the limit is from the machine. And in the spontaneous modes of mechanical ventilation, all the three is from the patient itself. And we'll discuss briefly regarding the basic modes of ventilation, which we commonly use in the clinical practice. So first thing is the controlled mechanical ventilation. In controlled mechanical ventilation, the ventilator will deliver the preset pressure as well as the preset volume in a time-dependent manner. So there will be complete control of tidal volume as well as the respiratory rate. So indirectly controlling the complete minute ventilation. So you can't, the patient can't breathe in this mode of mechanical ventilation. So there is no spontaneous breaths which are allowed in this mechanical ventilation. And it is commonly suitable in heavily sedated patients or those patients who can't breathe because of the disease etiology itself. The main problem with this mode of mechanical ventilation is whenever the patient tries to breathe, there will be a lot of asynchrony as well as increased work of breathing occurs during this mode of ventilation. So it is not suitable for the patient who don't have any respiratory efforts, who has any respiratory efforts, and it is usually not useful for weaning mode of mechanical ventilator. And coming to the assist control mode. So whenever the patient is not breathing, so it functions same like a control mandatory ventilation. So it delivers the preset pressure as well as the volume in a time dependent manner. So suppose the patient starts breathing. So suppose the patient start breathing in between. So there will be additional breath, which is completely supported by the mechanical ventilation. So which is completely assisted and it will deliver just like a mandatory ventilation. The problem with this mode of ventilation is, suppose if you set the ventilator rate as 30. In between this 30 breaths, patient is taking around 10 breaths. So these 10 breaths are also completely assisted. So total breaths will be delivered is around 40. So the patient ends up in hyperventilation and then respiratory alkalosis and all. So this mode of ventilation is commonly suitable in those patients who are like properly sedated. And then one more problem with this mode of ventilation is breath stacking as well as the asynchrony is the main problem with this mode of ventilator. So this can be taken care by properly sedating all these patients who are on assist control modes of mechanical ventilation. And coming to the next mode of ventilation, it is intermittent mandatory ventilation. So same like control mandatory ventilation, if the patient is not breathing, it will deliver the preset amount of pressure and preset amount of volume in a time dependent manner. If the patient is breathing, suppose if the patient is breathing in between these two mandatory breaths, so these spontaneous breaths are allowed by the patient. There will be demand valve whenever you set this mode of ventilation. This demand valve will get open, and how much ever the tidal volume which is generated during this mode, it is completely dependent upon the patient. So he can demand how much tidal volume he wants. So that is what it is done in intermittent mandatory ventilation. The problem with this mode of ventilation is like, suppose if the patient is breathing here, then there is no issue. But if the patient is breathing here, suppose the patient is in inspiratory phase and the ventilator is also in inspiratory phase. So both leads to the breath stacking and there will be increased delivery of the pressure and increased delivery of the volume to the patient. And suppose if the patient is in inspiratory phase and the ventilator is in the expiratory phase, this results in asynchrony of the patient. So that is the main problem with intermittent mandatory ventilation. To overcome this problem, the next mode of ventilator, which is called as synchronized intermittent mandatory ventilation, is developed. So what it does is, see, so as discussed earlier, so whenever the patient is not breathing, it will deliver preset amount of pressure as well as the volume in a time dependent manner. If the patient is breathing in between these ventilatory breaths, so it will allow the spontaneous breath by opening the demand valve. And if suppose the patient breathes before, just before the mandatory ventilation, what we call as a synchronization window. This synchronization window will be there few milliseconds before this of mandatory ventilation. So whenever the patient breathes here, this mandatory breath will move forward, and this breath will be completely assisted. This assisted breath is like just like counted as a mandatory breath. So there won't be any additional breath delivered to the patient. Suppose if the patient is breathing around 10 rates also, it will the ventilator will give only 30 breaths as quoted in the previous example. So there are mainly like 3 types of breathing which are seen in this SIMV mode. So one is the mechanical controlled mandatory ventilatory breaths, and one is the spontaneous breaths which are allowed, and one is the assisted breaths. So mainly 3 modes of ventilatory breaths are delivered by the patient, delivered to the patient. And coming to the next is a pressure support ventilation. So it is like a pressure trigger, pressure limited, and flow cycle mode of ventilation. There will be decelerating flow. And this mode of ventilation is commonly used as a supportive mode. And it is along with the other modes of mechanical ventilation commonly used with SIMV mode, SIMV PC plus PS mode. And what it does is like it augments the spontaneous tidal volume. So there will be decrease in the work of breathing as well as the decrease in the spontaneous rates by the patient. So the work of breathing will be less if you can consider using this pressure support along with the other modes of mechanical ventilation. So there is no guarantee of tidal volume with the changing respiratory mechanics, and there won't be any backup ventilation if you use this mode alone. If you use this mode alone. And how much of pressure support is set is like if you are using the ET tube of around 3 to 3.5, 10 centimeters of H2O, and 4 to 4.5 size tube, the around 8 centimeter of H2O should be set. And if you are using the 5 mm or larger tube, 6 centimeter of H2O you can use. As a general rule of thumb, like you can use the half of the driving pressure, which is the P flat minus P. And this is the classical example of pressure support ventilation. So here, as we see in the previous pressure time scalars, so this is the mandatory breath, this is the assisted breath, and this is the spontaneous breath. So here we can see the spontaneous breaths are augmented. So there is an increase in tidal volume, which is delivered to the patient when you use this pressure support. So next comes is the PRVC mode of ventilation. It is known as with different names in different ventilators, like APC, variable PC, auto flow, VC plus, and volume guarantee, but all together depict this PRVC mode of ventilation. It is a dual control mode. It is like a time triggered, time cycled mode of ventilation where the pressure is limited and volume is guaranteed. So here the clinician set that decide tidal volume as well as upper pressure limit in this ventilatory mode. So it combines the advantage of both the pressure control mode as well as the volume control mode. In pressure control mode, there will be like a decelerating flow pattern or variable flow, which helps in minimizing the asynchrony. As in volume control mode, there will be like a stable tidal volume and there will be stable minute ventilation will be seen. In PRVC mode, it combines both the advantages of pressure control mode as well as the volume control mode. And how it works is like whenever you set the PRVC mode, so initially it will deliver this volume control breath to the patient. So after delivering the particular volume, it will calculate like how much pressure is generated, how much pressure is needed to generate that particular volume. So it calculates the P flat and compliance. During the next breath, it will deliver the same amount of P flat to the patient, and it will see like how much tidal volume is generated in the patient. So if the exhaled tidal volume is less than the set tidal volume, slowly the pressure will increase like in a setting of like 3 centimeters per H2O in each breath. And then it will equals this exhaled tidal volume as well as the set tidal volume. And if the patient's exhaled tidal volume is more than that of the set volumes, what it does is like this pressure control. The pressure will slowly dip by in the 3 centimeters of H2O, and it will make equal of this exhaled tidal volume as well as the set tidal volume. And the lowest possible inspiratory pressure to guarantee the tidal volume is used in this mode of mechanical ventilation. So the pressure increase or decrements will occur in the is usually done in the steps of 3 centimeters of H2O. The maximum inspiratory pressure is 5 centimeters of H2O below the set pressure alarm limit. So we have to set like what is the maximum pressure you are anticipating in this patient, and you have to set it, and 5 centimeters below that value, the pressure will be delivered to the patient. Okay, thanks. We'll discuss about other modes and all during this workstation. We'll have like a hands-on during that time. Okay. Any doubts regarding the issues, anything? Anyone?
So for 2 sessions, one we talked about initial ventilator settings and second we talked about different modes of ventilation. Now we have started on ventilation, right? Now after starting on ventilation, the ventilation cannot be smooth all the time. You can have some troubles while you're ventilating a child. So let's see what are the troubles you can face while you're ventilating a child, and to know what is the cause for the trouble, so that how can you troubleshoot that. So right. The problems while you are ventilating a child can be due to patient or can be due to ventilator, or there can be synchrony. Usually you have a synchrony between patient and ventilator, or it can be due to asynchrony. These troubles are depicted in the terms of either an alarm or a graph, to which you're gonna do some interventions. These are the things which we are going to discuss. So like for all practical purposes, you should make sure that you have been attached to the AC power. And secondly, you have a gas source and you have a pressures being all time checked. And the personnel who should be used, who are familiarized with that particular ventilator, should be using it. And there is something called servicing and testing. All the ventilators should go 6 monthly calibrations. This is something which, if someone is managing ICU, should go for it. So now, your patient is on a ventilator. Suddenly, you have a sudden onset of some bradycardia or desaturation. What do? You expect something, you anticipate something, and you're going to do something. What you're going to do? So we all think about the dope when you have a sudden onset of desaturation and bradycardia. What do you do at that point of time? You disconnect from the ventilator. You take onto the ambu. If the patient improves, your saturations are improving. The problem is at ventilator. The child is not improving, then the problem is at either the ET tube or related to the lung. This is how you're gonna approach. Then regarding the lung and rest of the things we'll discuss in the station, but this is how you approach to it. So hence you're saying that if you have only distress, which is not, I'm saying not a bradycardia or desaturation, just to have a someone is having distress when you are on ventilator. You don't have a distress when you are ventilating the child, right? You should be smooth. But if someone is having distress on someone on ventilator, you think either related to the patient related problem, it can be related to the ET tube, or it can be due to bronchospasm, or there can be pneumothorax, or you are giving inadequate sedation. You think in the terms of ventilator, there can be leaks from the ventilator circuit that could have lead to distress, or someone is having asynchrony. That we'll talk later. Someone is having patient ventilator asynchrony, then also you'll have respiratory distress on ventilator. So regarding the ET tube, if the ET tube is migrated, or if someone is biting or kinking the ET tube, then also leads to respiratory distress. So all these problems are depicted in the terms of alarms. So if you see the ventilator, you have different set alarm limits. As we have already, Kiran sir have told us different alarms, and you got deciding on how much you are going to keep those for this. But make sure that if you are ventilating a child, you see something called apnea time. So how much apnea time you wanted to have for this child? Like probably if you wanted to alarm to blow after 30 seconds, you'll give 30 seconds. So if you have this alarm volume, you keep it at high so that you'll be able to listen to the alarm so that you can respond to it. And all you have for PEEP, minute ventilator and respiratory rate, ETCO2, PEEP, all this will have a leak. Even the leak has got leak percentage also has a limit. So you're gonna set both low and high so that the alarm will be displayed, and you go and correct you will go and see for what reason we are getting the alarm, right? So we have 3 types of alarms. One is high priority alarms, medium priority alarms, and low priority alarms. So one thing which I would tell you is, if you have a red light being displayed on your ventilator, that is a high priority alarm. So that is something which is not an ignorable thing where you don't tell sister, just go and keep it alarm mute. You will go and see for what reason we are getting a high priority alarm. So this high priority alarm can be because of your low pressure or high pressures, or low tidal volumes or high tidal volumes, an apnea, ventilator going into the backup ventilation, or you will have a limited battery capacity. These are the most important high alarm volumes that you'll get on a ventilator. So if you have a low pressure, you have a low pressure alarm. What could be the reason? Predominantly the ventilator being disconnected. It would have been disconnected. That is the reason you are getting an alarm. Just that you go and ignore the alarm, just keeping the mute, then we are going to lose the patient, isn't it? So check if you are getting these type of alarms, go and see the patient. Or there can be leak from either the AT tube might have disconnected, or the ET tube might have displaced, or the expiratory limb or inspiratory limb from the ventilator must have been disconnected. You see for these things and you correct accordingly. Right? You see the problems. As I said, ET tube might have been disconnected or ruptured, or the expiratory limb or inspiratory limb of the ventilator might have been disconnected. You check for these things and correct it appropriately. High pressure alarms. So if you have a high pressure alarm, where that means the child might be coughing, probably you need to give more sedation. If you have, this is regarding the air, if you have lot of, I think most of you must have used a HME filter. So if you are using HME filter, usually we change it at 24 hourly. If you're not changing the HME filter, it will all pile up, all the secretions will pile up into the HME filter and it will block. And that leads to a constant alarm. So that is the time you should think all these aspects. We are going to get these alarms and you change accordingly. And if you have a high pressure alarm, as previously discussed, this high pressure alarm can be because of your P peak being high or P plateau being high. Right? Like, I'm sorry, either the high alarm can be secondary to, there is a worsening of the complex like ARDS, or there can be worsening bronchospasm that could have been lead to this high pressure alarm. That we have already said that this PIP and P plateau we have discussed. If you have the large gap, that is problem with the resistance. If you have a small gap, it is more problem with the ARDS. So this already been discussed. We will not go through it. So if you have a high minute ventilation alarm, consider the child is in pain. Most commonly, reason you get high minute ventilator alarm is the child is in pain. Inadequate sedation leads to this. You're going to address that. If you have an apnea alarm, check for your alarm timings, how much you have kept and all those things, whether there might be a leak or your sensitivity settings might be low. These are things you need to consider. So these are the alarms we are talking about. Now let's talk about the graphs. So we all see the graphs, like, you see scalars, you see loops. So I'll not go into details of scalars and graphs, but I'll show you few graphs where you can identify, looking at the scalars and the loops are for what reason? To look and identify a problem and correct accordingly, right? So if not, there will be no use. So tell me, what is the problem with this? This is a scalar. This is a volume time scalar, right? So here it is not touching the baseline. Can someone tell what is this? On a volume time scalar, where your volume is not getting completed, there is a loss of volume. What is the problem here? Leak, yes, air leak. So this is a PV loop, right? This is a PV loop, where here it is not ending over to the baseline, it is ending over here. Again, there is a loss of volume. If you're seeing this such type of loop, again assume this is an air leak. Air leak is ET tube leak. So same thing, if you have something called a flow volume loop, where there is a loss of volume over here. Again, this is secondary to air leak. These are the three different graphs by which you can identify there is a leak, ET tube leak, right? Now tell me, what is this volume time scalar is showing? See, normally this should end over here and you should start a new one, but it is going beyond this baseline. So usually someone actively exhales, someone is actively exhaling the excessive tidal volume, which is more than what we are asking for, then you'll get such settings. So what is the common cause for active exhalation? Someone is in pain, you'll have this, or there is a calibration error also can lead to this. You're going to address that issue. This is a pressure time scalar. Pressure time scalar. You have a concavity over here. In a pressure time scalar, if you find this type of appearance where there is a concavity, It is that your flow, whatever you are giving for the patient, is not sufficient. So usually, when if you see the Mackie ventilator, you don't have an option to change the a flow. What do you see if you find this type of scalar? The reason is flow starvation, and predominantly you would have been in a volume control mode of ventilation. Probably changing from volume control to pressure control mode can rectify this alarm, and can be your flow starvation can be corrected. So this is a fish tail appearance. So you have more length, that means increased work of breathing. So the patient is making an excessive effort to initiate a breath. What is the possible cause for this? So we have already discussed about a trigger. So normally if you keep between 1 to 2 liters per minute, the child is able to make minimal effort to make the initiation of breath. If you're keeping a higher trigger, probably 4, 5 or a pressure trigger, so the child should be making a lot of effort to initiate a breath. So if you're seeing such type of PV loop, where you expect your trigger is sensitivity is not appropriate, you will try to come down on the trigger. So this, I think most of you might know, this bird beak appearance in PV loop. If you are giving excess amount of pressures than what it is required for the lung, for that compliance, then you will see to over distension. So over distension of the lung will cause bird beak appearance in PV loop. See this in a flow volume loop, the expiration is not coming to the baseline, it is ending over here. Any idea? So this is the air trapping. You have a trapping over here. See, if you see again FV loop, you have a scooped out pattern. Why we are getting? This is lead to a bronchospasm. If you have a bronchospasm, your expiration will not be able to complete. So that is the reason you are getting this type of. This secretions that completes our graphs. Let's go about the patient ventilator asynchrony. I'll not go into the details. This is a bit complex topic, needs at least 30 to 40 minutes to talk about these things, but I'll show you only important things. So patient ventilator, what does mean by patient ventilator asynchrony? The patient and the ventilator should be in synchrony to have an effective ventilation. If that is not being displayed, if it is not there, then you will see something called asynchrony. So it can be trigger, flow, or cycle. I'll not go into the details. See, this is one important thing. Ineffective trigger. See here, the patient is making an effort. So small deflection over here, but the wave is not being generated. Right? This is an ineffective trigger. Probably you are keeping a higher trigger. That is the reason you are getting this. You decrease your trigger, then you lose this. Auto trigger. See here, this negative deflection indicates patient is making an effort. Here, without making a patient effort, you are getting two graphs without effort. This is called an auto trigger, most commonly secondary to leak. If you're finding this type of graph, look for you are having a lot of secretions in your ventilator tubings. Probably you have a mild leak. So correct those things. This graph, this asynchrony will be lost. Reverse triggering, no. Flow asynchrony, as we have discussed, pressure time scalar, you have concavities. So the take home message would be, don't ignore the high risk alarms, have a pre-test calibrations. Ventilatory graphics, you read well, you keep on looking into the ventilator graphics, you'll find a lot of information and you can correct many of the measures. Thank you. Any questions? We'll have our workstations. So I think we have one thing on, we have 3 workstations. One is ventilation in neonate. Second, we have ventilation in pediatrics. Third, we have some something on simulation, some troubleshooting. So we are going to have a similar way like 1, 2, 3, so that we can divide. We'll start same stress. We do we have the same number from the morning to the evening? Some people lost. If that is the case, then we can go with the same numbers, 1, 2, 3. So 1 over here, 2 over there, 3 over there. వాళ్ళకి ఇచ్చేసాను ఇచ్చేసాను
Okay.
The interface. These are the knobs or the knobs and the set or set knobs. The set measurements will be over the bottom part of the screen and always on the right side of the screen will be the delivered message. Right. So there are different modes. Okay. Done. Okay. So what are the variables in the discussion in the morning or the afternoon also, just half an hour ago, the phase variables were discussed, right? What is the trigger? What is the limit? Which one is the cycle? So which one is the trigger? It can be flow, it can be pressure, or it can be volume. Just the baby's inspiratory effort causing a flow disturbance or generating a pressure, causing a negative intrathoracic pressure also can be a trigger. So that sets the ventilator to assist breath by starting effort of the baby. It's an assisted breath, for example, right? So the control will be usually in neonatal ventilation, we take pressure as the control. We top it up with volume guarantee. We don't use the volume control majorly in neonates, unlike adults or in pediatrics, right? The cycling will be either it could be time cycled or flow cycling. Flow cycled mostly in the pressure support ventilation, time cycled in the other PS, the SIMV and assist control, IMV and TMV. Right. So each variable, do you guys know what is the difference between flow cycling and time cycling? Before I go into the modes of ventilation, how is it different? Time cycle or flow cycling? So from the discussion, we got to know IMV, CMV and SIMV and assist control are time cycle mode. That means there is a set TI, T inspiratory time by the ventilator. That means you, the user, which will control the baby's breath. Like for example, there is no free flow of the baby to breathe. For example, the ventilator starts the breath, for example, or the baby started the breath and initiated by the breath. The PIP starts building up in the inspiratory time. For certain particular time, the pressure stays there, and then slowly with the time, after TI is completed, the phase of respiration cycles into expiration, right? But in the meantime, does the baby not breathe or breathe? Depending on the pathology, baby can breathe. If it's a neurological baby for which the cause of ventilation is neurology, be it an asphyxiated baby or just the apnea of prematurity where lungs are okay, but there is an issue with the brain, the baby doesn't breathe. Okay, fine. Then that is just a set rate that is getting delivered. But in case it's a meconium aspiration or a respiratory distress syndrome where there are breaths, the baby also breathes, right? So there creates a problem of asynchrony. With the advanced modes of ventilation, we are able to sort out the little bit of expiratory asynchrony, but inspiratory asynchrony remains in all the modes. Be it SIMV, be it CMV, IMV, there's no doubt. Be it SIMV or assist control, there is asynchrony, right? So with the flow cycle ventilation, where the peak inspiratory flow rate reaches 5 to 20%, usually you can set it up. In this ventilator, you can actually set it up 5 to 20%. 15% is the usual norm. So at once the flow comes down to 15% of the flow, reaches the 15% of the flow. That means 100% CIFR to 15% of 15 ml of CIFR. From the inspiration, this changes to expiration. That means it is the TI will be decided by the baby. So the asynchrony part of it is eliminated. What happens if asynchrony is there? So what if asynchrony is there? What are the disadvantages? I mean to say, what are the disadvantages of asynchrony? There is no communication between the ventilator and the baby. What will happen if there is no communication? Yes, red stacking, auto peep generation, or it can cause actually air leak also. And most importantly, there will be alteration in the cerebral blood flow. Because of this up and down in the pressure, there will be variations in the cerebral blood flow, baby's blood pressure, in turn affecting the cerebral blood flow, right? So that is most important. That is what we don't want, especially preterm newborns, ELBW and VLBW newborns. So there, the asynchrony part should be addressed. So in case you use SIMV, attach a pressure support ventilation, because the pressure support itself is telling you it's a support form of ventilation. It is not a primary mode of ventilation. And SIMV, you attach a PSV. Assist control, you usually do not attach PSV. And second thing is, either you attach a volume guarantee in case of preterm, especially in preterm, because volume trauma is also more important in cases of preterm newborns. Actually, there are lots of experiments that have been conducted which say more than the pressure, high amount of volume causes more damage to the lungs that is implicated in the pathogenesis of sleep. Right? So when you look at these variables, how do you set each variable? For example, we'll talk with the easiest one, FiO2. How do you set FiO2? Yeah, for example, you attach the baby, you had a term baby, meconium aspiration. You didn't have an option of ventilation. You thought of you can try with CPAP. So you started CPAP. You are at an oxygen. You are at an FiO2 of 50% and a PEEP of 5. You cannot increase PEEP because you are in you have an idea it can cause pneumothorax. There is already air trapping and emphysematous lung heterogeneous disease, so you cannot increase PEEP. But the baby is requiring high FiO2, so you are at the verge of failing CPAP and you need to connect the ventilator. So usually you connect at least that or little more than that. Okay, 50 or 60%. And the main thing would be target saturation on the pulse oximeter. Any baby on ventilation, more than 21% FiO2, the target saturation should be 91 to 95. Lower limit should be at 89, upper limit will be at 96. Okay, your FiO2 has to be according to that. And the blood gas. Term baby 60 to 80, preterm baby 50 to 70. Your target PaO2 is so much. Right. Next is the peak inspiratory pressure. Peak inspiratory pressure. How do you set peak inspiratory pressure? Does it actually depend on the weight of the baby? Larger the baby, higher the PEEP. Is it like that? PEEP. Yes. Adequate chest size of the baby. That doesn't need to boom out. Just little bit next to the baby, you can see a chest. Hyper expansion is not necessary. That again can cause an obstructive shock-like situation. Okay. And what else do you need to check for tidal volume? The tidal volume that is being generated with the positive peak inspiratory pressure. And what else? Basically, these are all interrelated. Don't think that they are not related. You give a PIP of 12 and you set an FiO2 of 70. Does it work out? It doesn't work out, right? So depending on mainly on the tidal volume, how is the baby's chest expansion, and the FiO2 and other parameters, you set the PIP. For a baby who doesn't have a major lung issue, you can start with 12 or go up to 50. Right. Like for example, you are ventilating a baby for actually abdominal pathology. Lungs are absolutely fine. Baby had an neck and baby is in septic shock, say for example. Right. That lungs are fine. You're just ventilating the baby for a metabolic issue. Right. At that time, you don't need very high pressure. Very high PIPs are not needed. So you can give a 15 or 14 or 16 depending on your PCO2 and pH value. Right. Then next, PWP. How do you decide for positive and expiratory pressure? Yes, retractions on the chest, retractions on the baby, minimal or no chest retractions. You start with 4 or 5, you can go up to 7, 9. There are some units where they practice PEEPs of 8 or 9, but in India, we don't usually. We wait at PEEP of 7, still we get skeptical with the number of 7. Many of us do not use 7, right? Then how do you decide? And what else do you check for PEEP? Excuse me? Yes, lung expansion on the 6 to 8 posterior anterior spaces on the chest, 6 to 8 spaces. If you are at 7 or 8 space, it's better you stay there and you go back, because there is a chance for air leak, right? And it again is dependent on FiO2. PEEP rather than PIP determines the oxygenation. Okay, you know the formula of mean airway pressure, right? MAP. PIP into T inspiratory time plus PWP into TI by the total inspiratory time, total time for each cycle. So PIP and PWP influence the oxygenation. PIP more towards PCO2, PWP more towards oxygen, right? Then what about the respiratory rate? The same thing. If there is no respiratory pathology, you just go with 40s. Term baby, you go 40. No respiratory pathology. For example, you are ventilating a baby who has asphyxia, who had perinatal asphyxia, who didn't have spontaneous efforts at all. So you are on ventilator, minimal setting. Right. At that time, do you use a respiratory rate of 50? No, right. 30 or 40 would be enough. But on the same time, you have a baby who has meconium aspiration. Okay, there will be a lot of asynchrony if you keep at 30 and baby is breathing at a rate of 80. Right? Or you have a baby, a preterm baby, a 1.5 kg baby, a 32 week or 1.5 kg baby who has RDS, who is not steroid covered. How much rate do you set to that baby? Yes, 50 or 60. You start with 50. You, depending on the respiratory acidosis on the blood gas, you go up to 60. Right? What about the TI? T inspiratory time. Gestational age dependent. Usually in our unit, we do set a TIs of 0.28, but usually the normal teaching case, you start at 0.3, you go up to 0.45 also. But it actually depends on the disease condition of the baby. For example, a 25-weeker is born in the unit. So you started a TI of 2.26. So gradually, weekly, you keep changing the TI. If the baby is on ventilation. For example, the same baby got extubated, had a BPD spell, got sick, had an apneic spell, got sick, and is ventilated in the 5th week of life. Say. Why? For BPD, obviously, you will use prolonged TI, slow respiratory rate, and higher tidal volume. Understand? So it depends on for the same baby, you actually use different TIs at different times. Understood? So what about the IE ratio? IE ratio? Usually 1:2.5 or 1:3 maximum to that, because you don't want very short expiratory times, because I don't want any auto PEEP or inadvertent PEEP, right? So do you set flow in this ventilator? You can't set flow in this ventilator. It's auto set. The new modern ventilators have auto set flow. For example, in Dragger baby log, you can set the flow. If you are using the same ventilator for CPAP, 5 is enough. You are using the same ventilator for NIV or conventional mechanical ventilation, you go up to 7 to 10. But if you are using the same ventilator for high frequency, you go up to 15 liters. So there are certain ventilators where you set flow. Can you set flow in MACVIT? You cannot set flow in MACVIT. Only in Dragger baby log right now you use majority. You can set the flow. Rest all, most of them, it's inbuilt. How is it determined is 5 times the mechanical ventilation, so 5 times the minute ventilation plus extra for the circuit. For example, do you know how do we calculate the minute ventilation? Tidal volume into respiratory rate. So for example, the VTE is 6.5 here. Okay. So ml per kg, say I'm ventilating a 2 kg baby. So 3 ml per kg is the tidal volume, and respiratory rate is around 30. So how much is the minute ventilation? 3 ml per kg into 30, 900. Okay, so extra 5 times of it. Say for 1 liter, think of it as 1 liter, 900 ml or 1 liter, 5 times it. So 5 liters plus extra 2 if you are ventilating. Okay, in a preterm baby, it would be around approximately around 4 to 5. In a term baby, it will be around 8 to 10. because the minute ventilation also differs, right? The tidal volume itself is different, so it is the minute ventilation is still down. Got it? So how do you then, how are the modes different? CMV or IMV, there's no point in discussing because there is a lot of asynchrony. The whole mandatory breaths are given by the ventilator. There is no room or space for the baby to breathe. There is a lot of asynchrony. Current ventilator management doesn't use them now, CMV or IMV. So either we use assist control, or what are the other names of assist control in different ventilators? Yes, SI? No. Assist control. So there is another name for it here in the SLE. PTV. Patient triggered ventilation, PTV. So that in SLE is the assist control. There is another ventilator in Acutronic, you call it SIPTV. There is another ventilator in VN500 or VN500 or 600, it is assist control. In MACVET, it is assist control. In Dragger, it is something else. It is assist control. Understand? It's the same mechanism, but different names in different ventilators. Right? So what is the difference between SIMV and SIPPV? Do you guys know? What is the difference? TI, we'll look at all the parameters. FiO2, irrespective of the mode, right? It depends on the pulse oximeter and the blood gas, PaO2 in the blood gas. So PIP, is it set by ventilator? Yes. You set the PIP in both modes, right? Both in assist control and SIMV. And PWEP, the ventilator itself decides the PW. Respiratory rate, how is it different in SIMV? How is it different in assist control? I mean, how do they take the respiratory rate?
The rate is final each of the will be supported. Rate is
No, in
synchronization. The rate is falling in the synchronization window about the control ventilation. That rate will be
supported.
Yeah.
In assist control?
Set ventilation.
In assist control, there is no set respiratory rate. What is assist? What is assist? What is control? Any breath that is initiated by the baby will be assisted. In case the baby is not taking breath, baby doesn't have any breath at that moment. Like for example, say there are only 10 breaths. Okay, if you set a rate, apart from the 10 breaths, the other machine will deliver other 50 breaths. So basically, baby breathes, that those many breaths will be supported. If baby doesn't breathe, machine will deliver those many breaths. In SIMV, for example, you have set a rate of 30, but the total rate is 50. So this 30 rates will be supported. The other 2 breaths will not be supported by the ventilator. If you attach a PSV, pressure support ventilation, like sir said, then those breaths will be supported till the PIP. PSV, the PSV support you have given. It could be 50 to 75%. For example, a PIP, you have set a PIP of 15. So the pressure support you can give up to 12, 75% of the PIP, right? As and when the disease becomes better, the baby is getting better, blood gas is fine, lung parenchyma is better, you can come down on the pressure support. Slowly you can remove the pressure support, you can come down on the PIPs and rates and think of getting the baby out of the tube. And
control ventilation apart from assist ventilation. So more hyperventilating is assist control.
Assist control, exactly. Assist control on more hyperventilation. There is a scope for more hyperventilation because each and every breath will be given the full pressure. For example, baby is breathing at 70. 70 breaths will be given full support. Then there will be hypocardia, right? So at that point, if the baby is breathing more than the physiological rate in assist control, you need to sedate the baby. If you are not in a habit of sedating the baby, if you want to synchronize, there are some units where sedation is not used, right? Another preferred mode is SIMV plus CS. Some breaths will be supported, some breaths will be done by the ventilator till the maximum PIP. The other breaths, the spontaneous breaths of the baby, will be supported till the PS, delta P, pressure support only. Got it? So that this hypocarbia will not be there with SIMV. Just plain SIMV is not desirable. You attach a PSV so that the synchronization will be better. You had something. The rest of the breaths will be supported by pressure support. The full PIP will be given to those. Breaths will be only the pressure support, how much you have set will be given. Those will be receiving around 7, if you have set a 75% target, 75% only, 60% or 60% of the support only will be given. So there is a spacing, right? All the breaths will not get the full pressure support. So in this babies, usually many of them use it for a weaning mode. Initially, for example, preterm RDS, most of us, at least in our unit, we start with assist control. Assist control, that is assist control plus VG. Good amount of VG is what we start with. Slowly, once the tidal volume requirement decreases, the pressure requirement with the, when you check the pressure requirement, if you see day by day, the pressure requirement decreases for the same tidal volume because the lungs are getting better. There is no, the FRC is getting better, right? Then we slowly remove the VG, come to lowest set, we shift to SIMV, remove the VG, shift to SIMV, come down on the pressure and plan to extubate. Got it? And what about the TI? In SIMV and assist control, TI will be set by the ventilator. That means you will set the VG. But pressure support ventilation, PSV, is a flow cycle ventilation. Okay, there is termination sensitivity, right? And termination sensitivity means the percentage of peak inspiratory flow rate where the inspiration gets cycled into expiration, right? So that means TI is set by the baby in pressure support ventilation. When the flow comes down, automatically it cycles down, right? Ventilator is not setting it. You have put the percentage of peak inspiratory flow rate. TI will be decided by the baby. When the flow comes down to that particular percentage, will the baby be space out into the expiration? So TI will be set by baby in the PSV mode. The rest all will be set by ventilator like PIP, PWT, FiO2 will be set by you. Respiratory rate also PSV. In PSV, baby only will decide the respiratory rate. You just will keep the backup rate. In case, for example, do you guys know about spontaneous breathing test, SBTs? We do. Probably in PSV you will do it more than in NICU. What do you guys do? The problem is that cannot be done in NICU. So what we sometimes, not many people do it, but we used to do it. What we do is, if you think baby is ready in a situation where you can extubate the baby, baby has enough spontaneous breath adequate, tidal volume is being generated, and gases are fine, X-rays look okay, then we try the baby on PS. Okay, we see how many times the ventilator is giving backup rate. Is it very frequent in a minute? Like maximum we try with the baby around the doctor, we see if the baby is able to ventilate, self-ventilate on their own. The problem is the ET tube, right? It will be like babies breathing against the ET tube. So that is the reason where you cannot leave the baby for very long and you have to be around so that there will not be any desaturations or bradding. Okay, then you leave the baby on the ventilator, see how many times baby is taking on their own or baby is requiring the backup rate from the ventilator, PSV. Pressure support ventilation usually is not the main modality of ventilation, it's always a backup. Understood? And how else do you decide the PIP? Apart from the tidal volume, does PIP test, right? Mainly tidal volume. And additional, I forgot to ask you regarding the trigger sensor, trigger limit. So how much do you set the trigger? If you set the lowest, that means you're giving space for the breathing. Baby is breathing. That means you are letting baby's breath to be picked up by the ventilator, and that breath will be supported. If you have set the trigger limit to very high, like 0.6 or 0.7 liters, then baby will have to breathe a lot again for the breath to be detected. It takes a lot of effort for baby to initiate one breath. Okay, that is the trigger. And the most of ventilation, about volume guarantee ventilation. Do you guys use volume guarantee? No. In Nilofer, do you use volume guarantee? In Gandhi, what is volume guarantee? Why are we in units, an unitologist after volume guarantee in units? Preterms especially, why? What is it so beneficial about volume guarantee? Volutrauma, yes. FRC? Okay, so the thing is, it is shown to decrease the incidence of air leaks, decreased incidence of bronchopulmonary dysplasia. Okay, so decreased incidence of hypocarbia and decreased incidence of PVL also. Okay, in preterm baby who has PVL, you know what are the incidence of baby being a spastic CP child, right? So how does it, how does volume guarantee work? Any idea? So what is the tidal volume that you set in different kinds of babies depending on the disease or the weight? Preterm, term, do you guys know what is the usual tidal volume range? 4 to 6 ml per kg. It's 4 to 6 ml per kg. Lesser will be in the term newborns, more will be in the preterm newborn. So 5 to 6 or 4 to 5 in term, 5 to 6 in preterm. So for example, you had a 1.5 kg baby, just for familiarity, 1.5 kg baby who had RDS, delivered emergency LSES, mother had abruption, delivered emergency LSES, there was no steroid covered, so baby will have respiratory distress syndrome, and as there was no spontaneous breathing, you had to intubate the child. So you had given surfactant also in the delivery room. You brought the baby, you need to attach the baby to the ventilator, which tidal, and you are working in a unit where volume guarantee is the norm. So how do you set the volume?
1.59 ml.
Around 5 ml per kg, you can start with around 5 ml per kg you started. So usually what many people, what they do is, if you put them on a normal mode, the requirement of pressure you can understand. Depending on the tidal volume, you can understand the requirement of the pressure. So with that help, you can attach a VG and set the PIP. For example, you started the baby on assist control. You have set a PIP in that baby, for example, you had set a PIP of 17. Okay, that baby's pressure is varying between 15 to 17. Okay, then what is the PIP Pmax that you set in the volume guarantee? 3 to 5 above in units. For example, if you take 17 as the highest, maximum you can set up to 20 or 21. That is the Pmax. Right. So for this desired amount of tidal volume, the ventilator has to generate pressure in such a way that this amount of tidal volume will be delivered in each breath. This is like a feedback mechanism. Depending on the previous tidal volume for which the pressure was generated, the next breath also will be generated in such a way, with that pressure itself, the baby has to generate that amount of tidal volume. So for example, as the days progress, as the disease gets, the baby recovers from the disease, baby will be able to generate same amount of tidal volume with lesser pressure. That's how you will understand lung is healing. That is why it is called auto-weaning. So if you realize that in the initial stages of the disease, if the pressure requirement is very high, say for example, some babies will require a pressure of 24, 25 hours, then it would be better to come back to, we usually do not prefer volume guarantee. If the pressure requirement is very high because it constantly keeps alarming, you need to see what are the other reasons. For example, tube might have gone into right main bronchus, or there is a tube block. More or over? More. Okay. Okay. Tube is in the right main bronchus. You correct it, it will be okay. FiO2 requirement will decrease, pressure requirement also will decrease. Or there is a block in the tube. Sometimes it was an esophageal intubation. It was not in the right place. So there would be different reasons. Or there is a leak in the circuit. Simple first thing. So all these things you correct and then see why is the baby requiring high FiO2 or high PIP. Understood? So what else you guys want? Depending on what you ask, I'll try to talk. See, this is all one thing that I will always tell is you want to go to a place from A to B. The distance is around 10 kilometers, whichever distance you want. Okay. So some people drive one car, some people drive another vehicle. You will, the best fit would be whichever you are comfortable with, whichever you know how to drive. I don't know how to drive a Ferrari. Okay, not many people know probably how to drive a two-wheeler also. That same person cannot drive a two-wheeler, I cannot drive a Ferrari. Understand? So whichever you are comfortable, you know very well which is best for that baby. Like for example, there is a situation when you feel PIP should increase. Depending on the tidal volume, you thought the delta P should increase. That means P should be constant, but PIP should increase. You should know when you will increase, right? When you will increase, when you will decrease, depending on the blood gas, or when you will decrease the PEEP. For example, it should not be an improportionate setting. FiO2 sitting at 70 and you cannot have a PEEP of 5. There is a scope for increment, right? You can increase PEEP up to 6 or 6.5. So that should not happen. PIP is sitting at 12, FiO2 is at 80. What's the point? Many times we see that happens. PIP is at 14 or so, 14 or 15, but pressure is FiO2 sitting at 80. There is a scope for increasing PIP, right? Unless you give the adequate expansion, even if you give oxygen, it won't be enough. The map is not getting delivered, right? Mean airway pressure is not being generated. Just giving oxygen doesn't matter. The mean airway pressure is what actually matters. So it could be SIMVPS or assist control. If it is conventional ventilation, baby requires high frequency, it's another different ballgame. Which mode are you comfortable with? SIMVPS. Most of us use SIMVPS. And what mode do you use? SIMVPS. Assist control. Okay. Don't you attach pressure support ventilation to SIMV or just plain SIMV? Okay. And you, madam? SIMVPS. And you guys? Neonates, we are not SIMVPS only. PCS. Okay. So do you none of you use volume guarantee? PCV, VG you guys use. In PSU majorly. NSU also you use PG? Yes, you have that. The best way would be assist control. Assist control. Because you are abolishing baby spontaneous breath, right? So ventilator will deliver the breath. Volume no, in neonates we usually use the pressure limited ventilation only. You attach a volume guarantee so that the volume trauma is prevented. Usually it is volume pressure limited only in neonates, unlike in adults or pediatrics. That is the main difference here actually. And any what is dope and so do you guys use this mnemonic when there is an acute deterioration of the baby on the ventilator? So how often do you guys do blood gases while the baby is on ventilator? Very subjective. So what does this practice depend on? Blood gases on baby for a baby on ventilation. Okay, cost. So keeping the cost and all that logistical issues aside, what decides investigation? Any acute changes? Yes, that is SOS. Otherwise, routinely. Okay, before weaning, if you are planning to wean, why do you need a blood gas? Yeah, any worsening or acute deterioration, the baby had an air leak or there was a tube displacement or there was a tube block, whichever is the reason, you do a blood gas, or otherwise routinely. For example, there's a baby, a meconium aspiration with mild to moderate PPHN. So you think there will be a requirement of ventilation for around 3 to 4 days, for example. So how often do you do gas testing? What determines the frequency of blood gases in this kind of a case? No ideal actually, depends on your unit protocol. Some depending on the sickness of the case. If the OIs are very high, pressure requirements are very high. Depending on the condition of the baby, you can do it 6 hourly, to 8 hourly, or 12 hourly, depending on the initially it would require a little more. Or acute deterioration is always first thing that you do is check for gas and X-ray. But otherwise, if the baby is getting better, you can decrease the frequency. Which ventilators do you use in your hospital? SLE and chiller. Okay. No MACWET, no VN500, no MACWET. You might have had Nalka sign. And you baby log, dragger baby log. So you use high frequency in that. That ventilator doesn't have. Some baby log 500 ventilators do have high frequency, but the amplitude frequency is still the same. The amplitude that you set is very high. Usually you can start with the triple of the MAP, but in dragger baby log you need to set up to 85 to 90 amplitude. Then only there will be the wiggle come. Then you, sir? MACWET, very good. You guys? SLE. So you are quite comfortable with SLE. G ventilator. And you, both of you? Chiller, you? SLE. And any other doubts you have? Humidification, I'm not going to touch because it was already spoken about in the morning. My colleague Dr. Sindhu must have spoken about humidification in both HFNC and CPAP, right? So that part will be taken care. No doubts in ventilation. You're all perfect, quite comfortable. I can't see any question mark faces also. You guys either must be sleepy or do you guys use PSV for this SBT form for the breathing test? You guys use PSV to check how many times the baby goes for backup rate. CPAP PSV you guys use? FiO2, no, before weaning off, it's a trial for extubation. So FiO2 less than 30, like for example 25, 28, 30 is also fine. On CPAP itself you can give 30%, right? And the pressure requirement is very less. Then you can try CPAP PSV to see that if the baby is ready to be out of the tube. You guys do not use SPT. So how do you decide how do you wean clinical condition? Do you guys use CPAP for meconium aspiration? Yes. So there is no misconception of causing pneumothorax on CPAP. So you guys know you use CPAP for meconium aspiration. And about the graphics, any idea about the graphics? What do you do? For example, when you troubleshoot, you think about the dope, right? Displacement, obstruction, pneumothorax, or equipment error. Apart from that, on the ventilator, what is that tool that is very helpful that will actually help to tell you what is happening? Is it the equipment error or the issue with the baby, or in between, circuit or the ET tube? What is there on the ventilator screen that will help you in guiding you, that can give you a clue to what happened? Why is the baby requiring higher FO2 or high pressures, or why is the baby becoming cyanotic? Graphs, right? Scalars and loops. For example, in about other In another condition, like for example, you had given surfactant to a baby, an RDS baby, the compliance improves, right? The PV loop stands up once the compliance improves. So that way also is helpful. In pressure, flow and volume, you can actually check, right? If is it a flow cycled breath or a time cycled breath. You can tell in the flow volume loop, flow and time loop, right? If there is auto trapping or leak, you can tell in the volume time curve. In PV curve depicts the compliance. Flow volume can tell you if there is any obstruction or if secretions are there, intrathoracic or extrathoracic airway obstructions, or if there is a secretion or is just a lower airway issue, that also can be told. Anything else you guys want to know? Anything else? Pause. Single breath test. Usually, for example, if an RDS wave, a baby with RDS, spontaneous rates are good enough. Tidal volume generated for the lowest pressure. Like for example, you brought the PIP to 12 and PEP to 4, and FiO2 requirement is around 27. So you think the baby is ready to be extubated. This much amount of support can be given through CPAP. So at that time, what you can do is there in MACUTE there is CPAP PSP. So on the ET tube itself, you can see tube should not be blocked because baby will be breathing with the tube even though vocal cords are shut because of the ET. With that, you attach CPAP PSP. You start that mode CPAP PSP. It's clear in MACUTE actually. So you have a setup rate also along with that. So how many times the machine goes for a backup rate, it appears on the screen. For like say 10 minutes or 20 minutes, you can see to confirm if there are spontaneous breaths enough, the baby can take care of breathing on its own and then can be extubated. Simple it is, but you need a bedside doctor to monitor if baby is going for backup rate frequently or it is baby is breathing on own, generating adequate tidal volume. Depending on the baby, if the pathology is better, like for a meconium aspiration syndrome, you can set a rate of 30. Usually, term babies, meconium aspiration, if there is no neurological insult, they breathe on their own. It should not be a problem. This backup rate will be helpful in babies with apnea. Preterms who had apnea, preterms ventilated for other reason like NEC or septic shock or BPD, their backup rate will be helpful. If neurological, done. They're almost, yes. You depends on the disease condition. Preterm baby, you set a backup rate of 30 or 40. Term baby, you can set 40 or 50. Usually, term baby, it won't be an issue because a baby who has neurological issue, you do not do SBT because baby will not breathe. The cause for neurological issue needs to be found and then it has to be dealt. There is no set criteria actually. It is not the recommended, the 100% foolproof recommended way also, but some units do use. Frequently, it's better you don't because there is a possibility of extubation failure. Once or twice, okay. 5 to 10 times, I think there is a time for you to wait. Still, there is time. Okay. Basic thing, okay, not in depth in ARDS, but the basic thing when you encounter a patient with ARDS, what all you need to look for. Just like a case scenario, okay. So we have a 4-year-old child with high-grade fever with cough and cold and fast breathing for 2 days, okay. And in view of worsening respiratory distress, child was intubated at referral hospital and transported to higher center. So now these are the settings. After we intubated the child, we started on ventilator, started on pressure control mode. Okay, peak pressure, PIP is 30, MAP is 15, PEEP is 6, okay. FiO2 is 70, respiratory rate is 30, eye time is 0.8, 4-year-old child, okay. On auscultation, bilateral air entry is present with crepitation, okay. ABG is showing pH 7.24, it's metabolic acidosis basically, okay. Metabolic acidosis with the increased PCO2, okay, metabolic and respiratory. So is this ARDS? So we will not go in depth in ARDS, okay. Basically, to classify ARDS, there are a lot of criteria as per the PALIC guidelines. So these are the criteria, okay. Right? Based on the number, you will be able to mild moderate. Okay. So before classifying as mild moderate, it is important to identify whether it classifies into ARDS or not. So this child, if we calculate the PF ratio and OI, it fits into ARDS. We'll not go in depth about the numbers, about the calculation. Okay, so it's a case of ARDS basically. Okay. So in ARDS generally, okay, we go with a lung protective strategy. Okay, we have a few things like we limit the tidal volume as discussed in the previous classes. We go with physiological tidal volume. We limit the driving pressure to 15 or less than 50, and we limit the P flat to 28 to 30. So generally, if the chest wall compliance is reduced up to 32, we can go, but generally 28 to 30, we keep the plateau pressure. Okay, and we keep optimal peak. So what is optimal peak? We'll discuss in the further slide. Okay, so these are all lung protective ventilation for ARDS. Optimal peak, driving pressure less than 15, plateau pressure less than 28 to 30, and physiological tidal volumes of 6 to 8 ml per kilo. Okay, so now how to select an optimal peak? So the definition of optimal peak is there should be stable hemodynamics. Okay, a peak at which the hemodynamics are stable, the oxygenation is nicely maintained, the compliance is maximum. Okay, there is a high compliance or the maximum compliance. Okay, the driving pressure targets are maintained, that is it should be 15 or less than 50, and the P flat targets are maintained. Okay, so what is driving pressure and what is plateau pressure? As we discussed in the previous class, the plateau pressure is the pressure which is needed to overcome the lung compliance. Okay, and how we calculate it. Okay, so that is plateau pressure. I will tell you how to see the plateau pressure also. And the driving pressure is P flat, plateau pressure minus the peak. Okay, that is driving pressure. So this plateau pressure is definition wise, I said it is the pressure needed to overcome the compliance, that means to open up the alveoli. So on ventilator, how we calculate we see the plateau pressure is, first we put the patient in whichever mode is there, we put the patient on the volume control mode first. Okay. So now it is in volume control mode. So you put an inspiratory hold. So the P flat is the pressure at which there is no flow. Though there is no flow, that means there is no flow which is overcoming the airway resistance, only for overcoming the compliance. So at which there is no flow, there we get one number. You put an inspiratory hold here, then it will give you a number here. Okay, so that is P flat. Okay, so P flat should be 28 to 30, not more than that. Okay, and driving pressure. Driving pressure is what? P flat minus P. So at this point, suppose we start with a PEEP of 6. Okay, here we in this case we have seen that the PEEP, it was started with PEEP of 6. So how do we say whether the PEEP
few methods. There are few methods that you can calculate the optimal. So one is incremental and or these are these come under equipment. But you can go, suppose there is a worsening in ARDS. your inhalation. Now we want to maintain an optimal. So now at this peak, you increase your peak by 2 points each time, 1 or 2 in increments of 2. And then each time you make a note, you make a table, you make a note of your business, you make a note of your plan business, you make a note of your time, and you make a note of your confidence. So your peak of 6, so you got a peak of 8. Each time with increments of 2, you calculate all the values. Now you increase the peak of 8. With peak of 8, I will say that it will be more.
All of you are getting
Understanding, right? Anyone who is not understanding?
basically we are managing a patient of here. Right? And here you have all the alveoli water or collapse or exudate. You need to have a good amount of peak. There is something called optimal peak. Optimal peak is like what is the best peak for that particular patient, that particular scenario. It can someone says keep 8, someone says keep 10. Here it is. So we should know which is the best peak for that particular patient. Normally for regular patients, you keep something for 5 or 6 and you get a nice day. You see the post rates of the 9 to 10. It is more than 10, your peak is high to decrease the peak. Otherwise, 9 rates is good enough. 7 is sufficient. In the terms of ARDS, why you want to have a peak is insufficient. Know the balloon concept, right? If balloon is completely collapsed, to inflate the balloon, you have a higher pressure. If a balloon is partially inflated, then pressure circulation further will be less. If overly inflated, then you don't have much space to move. If you want to have an inflated lung to decrease the pressure requirement to inflate further. It is completely collapsed, pressure will be further. Partially inflated, pressure will be further. You have to keep where your most of the alveoli will be open, right? So in ARDS, so some number cannot be random. We can't choose the number randomly. That's why we dictionary is for this patient. There are different ways of assessing which peak is good for the patient in terms of ARDS. One of the most commonly frequently used method to determine the peak is the peak titration. So there you give a term called peak optimal peak. The peak at which you have least driving pressure. Peak or peak at less than 28, highest compliance and stable compliance is your optimal. Here we spoke about 3 terms. Peak or peak driving pressure. Third is compliance. Compliance we have discussed. Highly compliance means it's a good luck, right? So if you have a low compliance, it's a bad luck. So here we are going to keep some number on it randomly to chosen as 6, on which you want to see something called deflating. She is already told that what is the driving pressure. Deflating minus TW is your driving pressure. Make a table like that. There is a table there. This is a table where you got PWP, right? You have PWP.
Each time you are just going from 5, 7, 9. So you are increasing your peak. And with each peak, you are PIP. PIP or PP is the same. Okay. So your peak ranges, your plateau ranges, your driving ranges is from your peak by minus your driving ranges, and your compliance. Compliance will be happening straight here.
Now change to PWP of A. Already on 6 you have taken the parameter. Look at PWP. Now as that previously for spreading world. Why you keep it spreading world? The pressure in the alveoli when there is no air flow is called feedback. You keep something called the pattern also then P flat. This P flat you might you know this P flat minus PWP that is called driving pressure again you know, right? So the next thing that you check for is compliance P time dynamic compliance 2 by number of
So we have to go through certain parameters point at which you stop doing this. Like you have a keyboard elements which are being monitored. The high fidelity reduce the payload, lead to high potential. Over inflation can lead to the research. These are the two things you will stop it. Or you are getting a key peak more than 30. Then no vessel, otherwise around 30. That is the time you will stop. Or getting the key. Ideally set 2 minutes. I don't think no one will get it. Will take at least 45 minutes. So 4 to 5 minutes is good enough to change the time. Whether you reach to 30 or you change your keyboard or you have some part where you driving time is not the cutoff point. You reach to a point. If you see this table, incrementally you increase it from 5, you went up to 15. Right? You wrote all the variables that you got in the ventilator. Right? And from 15, you are coming back down again. 15, 13, 12, 11, 10, 9, 8, 7. You come back again. So again, you write the same variables. You will get set of variables. This is closely the table. The variables that you got during the ascending form PWD of 10 might be different on descending. Reason the more we initially you made the value to open up more, the equipment will happen on point. That will help in better confidence. So your values will be more better than descending. So hence you will choose a value of PWD on the descending table. Now looking at the table, tell me which PWD is ideal for this, optimal for this. Can it be 7 or 4? What do you want? You want a driving pressure and your comp needs to be high. And your peak should be less than that. Right? So if you see there is between both 7 and 9 has got a one component being high in one thing, a driving pressure being value between 7 and 9 would have been highly for this. So 8 I will change from my tier 6 to 8 for this. This is how you make this one method of knowing which is optimal for this application at that particular time. We are not talking about the rest of the time. So once you set peak direction, doesn't mean that you this is the peak. It doesn't hold like that. The child's condition is worsening. Then the peak required the peak after maybe 10 or further more. So again, you do peak direction, you understand the best peak for that.
So they get into the assist of decide on this. So now you have done your titration here. Okay.
Expect to keep titration also. Is a patient of care or moderate. Still the saturation are not oxidation are not. What you can do, each of the food pressure that means of effect right pressure. This is a Chinese oxidation messes are getting worse. What will you do at this point? One is chronic. Do you have any? What do you do is called a recruitment method. By which you will try to you will try to recruit all the collapsed alveoli. There are different methods of doing recruitment. One of the most commonly used method is So I think have you seen all of you have seen cloning? How does it cloning? Use very good results, but still many units have a tendency not to do a cloning. Reason that it comes up with one easy process to do it. Have a good approximation. Is recruitable, not problems which are not recruitable. Definitely, but the way people does not follow this has comes up with own complication. Like when you're cloning, your line can be
then there are chances that there will be so before that, make sure all is fine. But the other two people will be supporting. One person definitely takes care of the head, taking care of the center. The other person will be standing towards the side and one person towards the other end of the patient. So now we prefer turning the patient towards the side. So now I will be holding the tube. One person will assist me here. And you're turning the patient towards the right side. First, whichever side you're turning the patient, that side should be below the chest. So this hand will come, place this hand below this. And slowly turn the patient to the right side. One person will be holding the hand and the right here. The other person will once you turn, one person should be taking care of the vital signs. Should be monitoring the vital signs. Okay. So you need to allot. Okay. One person definitely who is taking care of the tube will not take care of anything. They are dedicated only to take care of it. So now you turn, you remove the lead, connect the lead from the back. Okay. If you have to change the pitch, then in this position, remove the pitch, change the pitch. Okay. All your pressure points now. Okay. Put those pressure pads or whatever to prevent your pressure source, which is the abdomen, the knees, and all these things. Okay, your forehead, the child's forehead, all these are pressure points. Okay, so you put your pressure pads, remove your disability, other on the back, and now slowly turn the patient towards the side. And now once you have turned, okay, the head also should turn towards that side, whichever side you have taken. Before that, actually, so you have a limited space when you float. Okay. So when the child is defined, first move the child towards the opposite side, because once you turn, there should be enough space when you turn. Okay. So in the same position, if you are turning, he may come to the other end of the edge. So you may not have adequate space. So before that, move the patient slightly towards the other end, then start floating. Okay. And now you have flown with all the precautions. Your easily on the back, your pressure points are there. Your head should be turned to this side, to the right side. So you take care of the ET tube and slowly turn the head towards that side. And your arms and the patient's arms and the legs will be in the normal straight anatomy position. The arms will be in something like split loss position. Okay. So one arm will be like this, one arm will be like this on the bed. Okay. And you should again check for all the tubings if they are entangled or all these things you need to take care and you should take them on. And central lines and all, you need to take care of the central lines. This is the main procedure of coding. Ensure that sometimes we keep a pillow or something like that below the chest also, so that there is adequate space between the bed and the chest, so that it helps in inflation. Whatever the ventilator pressure is, it helps in inflation and it doesn't press the chest. Okay, so that is one thing. So it needs a team effort. Basically, you need to take care of the tubing, you need to take care of the monitor, the vitals, you need to take care of the central lines, okay, ECG needs and all these things. Any PD, so there are some relative contraindications, like having a peritoneal catheter and HD catheter and all these things, you may not be able to throw. And hemodynamic instability is a contraindication. So you may avoid throwing in hemodynamic instability. Otherwise, throwing helps. So it improves the VQ mismatch. Okay, it helps in secretions, drainage of secretions and all these things. So in severe hemodialysis, you can still consider cloning if your previous strategies, lung protective strategies are still not helping. You have went up to your optimal peak, still your oxygen saturations are not improving, your X-ray is worsening. You can still give a trial of cloning before you go to other modalities.
Are we clear on cloning part? Cloning, once we do the cloning, make sure that we have a good monitoring system to check the patient. You will be most of the time a lot of secretions will be pulled up at volume. You have a pressure source. Your eyeballs will be swollen water. How long you will do cloning? Maximum is 60 hours. Maximum is 60 hours. Once you grow, you can continue the cloning for 60 to 8 hours. Make sure that you are doing in a time where everyone is around, so that a team can be formed and can be done in a very safe way. proning helps. Now this patient after proning has done reasonably well, maintained saturations. Now suddenly sister has called you to look the child is having desaturation and bradycardia. So you saw the patient having desaturation and bradycardia. What do you do? What do you do? Those are desaturation, bradycardia. Sister has called. You are in front of the patient. What is the first step you will do? We all know that this concept of dopa, but still somehow our initiation to do some process of just disconnecting from the patient. We take some lag. We try to do for ultrasound, we look for something and something else. We miss important period over there. We feel there is a desaturation bradycardia, take on bagging immediately. Because since it's such a sick patient, it will be always study for all the complications. I said preparation for complications will help in better recovery from the complications. In such type of patients, tube displacement, tube thinking, secretions blocking the AT tube, or you have something called pneumothorax. All sorts of complications can be possible here. So you expect those complications and you will be prepared for those. So you expect something called DOPE, right? So where you disconnect from the ventilator, you do something called bagging. The child is improving, means the problem is at the ventilator. If the child is not improving, you look for the other causes. Probably your ET tube was in situ or not, or there is an obstruction of the ET tube, complete tube blockade or not. If both things are being what do you call, remove both the causes, then you look for a pneumothorax. How do you detect the pneumothorax? So how do you detect the pneumothorax? Typically, you look for the air entry. There is a differential air entry. One side of the air entry is not there. You will expect some problem with that part of the lung. Can be pneumothorax. It can be large collapse just by the air entry itself. Can't be called to. Your expectation of pneumothorax would be high, but they say place it you not taking that further based on the air entry. Right. So what else you can get? Transformation is done for the newborn. Here we can do so much just small, so much supporting the fat, no transformation. Ultrasound test is something we have it set the most useful way of detecting the pneumothorax. You place your medial probe on it, you see for two important signs. Easily, this is something called sliding scan or barcode scan. The slide, if the pleural line is not going with the respiration, that means there is a pneumothorax. You don't have B lines, then it is pneumothorax. Then it is pneumothorax, right? Then you place stop button. And you get it next step, you get a picture like this. How you manage a condition. Basically, our context for this session would be to teach you how do you make the choice of the PWP in ARS. Second, how do you manage if you are all the sources of management of ARS like preparation or what recruitment can be done for that patient to improve the oxygenation cases. Third, if you have the complications like have some sudden onset of bad or dope like how do you manage? These are the only things that you want. Any questions regarding this? What? Yeah. You have to have a P clarity for P to detection of P clarity. What we are doing is a P titration. The wrong PRPC mode also. You can change the PC mode also. You can change from the PC mode to PC mode, and you do P clarity by doing P titration by doing protocol. You don't need the pressure control. You don't need to change completely the mode of the PRPS. Your choice. The golden rule mode. Whichever the